0 for now. Upper Detroit East, Dr. Akolo and his team are they here? 0 for now. Triple A, Dr. Hollison and his team are they here? 0 for now. Next slide. St. Gregory, Dr. Yemo and his team, St. Gregory, 0 for now. Mercy Wing Catholic Hospital, 0 for now. Ankapo is proceed.
Taking the zeros. Is anybody taking the zeros?
No, we are picking it.
Okay, good.
Ankapo Leprosy General Hospital, Dr. Kwao and his team, 0 for now. St. Francis Xavier Hospital, Dr. Cheneboa, 0. Mother in Child Hospital, Dr. Danso and his team, present 2. St. Luke Catholic Hospital, 0 for now. Alvina Hospital, Dr. Dazi and his team, are they here? 0. Asiposu Hospital, Dr. Prempe and his team, 0 for now. Kaswa Polyclinic, Dr. Johnson, yes, 1. Sing hand. What you are saying, Polyclinic, Dr. Priscilla, and okay, 1. Senior Polyclinic, 0 for now. Porting Polyclinic, Dr. Black and his 1. Brakwa Polyclinic, Dr. Mens and his team, Brakwa, 0 for now. Bisianse, Dr. Saki and his team are here. 0. Biwa Polyclinic, Dr. Maxwell, 1. Napa Polyclinic, Dr. Abba, so the team are not here, 0. Green Polyclinic, Dr. Pepra and his team, 0 for now. Chubraso Polyclinic, Dr. Sobi and his team are here, 0. The Rampon Polyclinic, 0. The NTCs, Chubraso NMTC, 0. Asinman, 0. Kekos NMTC, NTMC and NTC, 0. Dunkanofin NMTC, 0. Winneba Community Health Nursing Training College, Dr. Yossi and team, 0. Then Ankafo, oh yes, principal is in, great. So Ankafo present. Our SMC members, regional directors in DD 2.
Yeah.
Our regional internal director is also present, 3. Unit program managers at the RHG, 4, 5, 6 out of 32. Right. Regional Health Committee members, none present at the moment. Health Management Team, I've seen Dr. Bra. Regional Health Management Team, plus the SMC members, I've seen the Medical Director. Yes, so 6. That brings us to the end of the roll call. Ladies and gentlemen, Great. To begin today's session, we humbly invite our Medical Director, Trauma and Specialist Hospital, Dr. Kwame Fudibo, to pick up the chair for us. With a round of applause, let's welcome him. Our mother, our regional director of health service, she will make some remarks, after which we hand over the microphone to our chair, who will steer the affairs of this session. Thank you.
Thank you very much. Good morning, everyone, and thank you for coming. I think we'll call the rapporteurs to do the report before I give my morning remarks, and then the chair will continue with the panel discussion. So are the rapporteurs ready, please?
Yes.
Mr. Abaka, thank you. Wow. So please make it very crisp and short.
Thank you, Director. So, on behalf of the team, I stand here in the presence of Justice Abeka to give you the recap of proceedings yesterday. So basically, we're going to look at a brief introduction, we will look at the recap of the proceedings, the participation, that is the attendance, then we look at the chairman's a brief remarks from the chairperson, and then it continues with some panel discussions and goodwill messages. Okay, so by way of introduction, the government over the years has prioritized healthcare delivery in its quest for its public sector development. So towards this regard, the ministry has initiated a number of policies aimed at enhancing universal health coverage by 2030. So among some of these initiatives is the free primary health care policy, which grants each and everyone the opportunity to have access to health care in line with the universal health coverage. So going from that, the service over the period take stock, or weeks to take stock and to ensure and to review its progress and account for its stewardship. So it is against this backdrop that the Central Regional Health Directorate is this year organizing the mid-year performance review to take stock and account for health stewardship. So the team, looking at the proceedings as yesterday, the team for this year's half-year performance review, we all know, is accelerating universal health coverage through primary health care, CHPS, and then the network of practice concepts. So overall, in terms of participation, as of yesterday, we recorded 235 funds drawn from the various health agencies, partners in health, traditional authorities, among others. So when you look at the chairman's acceptance speech, in fact, we commenced the program around 9:30 a.m. And then the chairman, who happens to be Reverend Professor Amonu Kofi, and happens to be the chairman for the Regional Health Committee, accepted to chair. And then in his acceptance speech, he highlighted on cost-cutting issues and a reflection on the gains and deficiencies on key performance indicators. He also further promised to guide the review processes with fairness, focus, and respect, and ensure every voice is heard. And I think that even took us through to the late evening. Now, Regional Director's opening remarks. In her opening remarks, she touched on the theme that is, and then emphasizing that our responsibility to ensure that every person, irrespective of geographical location, and Mr. Peter Obri will be expert, will be making presentation on these health workforce challenges. Then they need to strengthen health promotion, community engagement, and then adolescent-friendly services, and then overall referral systems improvements. Now, we also look for, I think, beyond the presentation, that we will look at it. Mr. Obri Esquire will highlight more on that. The advocacy for recruitment, and then ensuring that we have adequate workforce. Then we're looking at the priorities from the regional director's speech. She outlined that we have successfully implemented the free primary health care while ensuring quality service, commodity availability, and effective claims management. We also looked at, we also expected that by February 2027, at least 30% increase in what? Functional chips. Then looking at fully operational network of practice concepts in every district and with clear referral systems in place. So let's look at some goodwill messages. We have Reverend Father Mignon from the child. In his goodwill messages, he commended the collaboration between the Ghana Health Service and child institution, and then with particular acknowledgement to the regional director for her leadership role. And then he also indicated that there's free fistula treatment for clients, that is at Mercy Women's Hospital. Now, the challenge with this is that identifying clients to assess the free fistula has been a challenge. And so he advocated for continued education on the services available to the communities. Now, so he also stressed that indeed free primary health care has come to stay and has become a reality. Now, from the COHETI, that's the College of Health Training Institutions, they emphasize on preventive care as part of effort to achieving the primary health care. In fact, part of primary health care is to ensure that we have we do the preventive aspect and then the promotive aspect of it. Now, he also commended the region for the continuous commitment in allowing the student to undertake the practical clinical experiences in our facilities, so which she commended the region for that. Now, with the regional ministers, he says indeed stakeholder engagement is key to achieving universal primary health care and, for that matter, universal health coverage. And then he also indicated that the government is committed to its infrastructure policy of ensuring that accommodation does not become or does not hinder the free primary health care policy. And in this regard, he indicated that as a matter of priority, the regional director should liaise with his office in ensuring discussions on accommodation challenges. He also stressed on immunization, which we all know that we are giving it a priority. And indeed, when you look at the indicators on the holistic assessment, at least some gains are being made in terms of immunization. Then the keynote address by the council rep, that is the person of Dr. Belinda Free-Nakon. In fact, she delivered a whole, over 40-minute speech. So, okay. Yes, I gave a comprehensive statistics on the team. Yes, and then also she highlighted on the continuous to ensure that through NOP, that's the network of practice, free primary health care, there will be focus and attention on non-communicable diseases. And indeed, one aspect that she spoke on, which it's worth noting, is that the school infirmaries to be part of the spokes for the network of practice. Now, I also stressed on the claims discipline, that's National Health Insurance claims discipline, and they need to ensure that we do that. In that regard, we're looking at the statutory regulations that you have credentialing and accreditation for all facilities for the National Health Insurance and HEFRA accreditation, among other statutory requirements. And of course, enhancing outreaches and home visits is key. So, Dr. Kofi Amedi delivered a solidarity message and expressed the council's commitment to support the region's health goals. So, there were also panel discussions, and two main discussions were held. That is making free primary health care a reality. That is the commodities and service delivery challenges, which we were all here and then we listened attentively and learned a lot from this panel discussion. And having NOP as an engine for the universal health coverage. On this note, thank you for your rapt attention.
Hello, good morning. How are we? This fine dear. I think it's too weak to be fine. Hello. How are we? Yeah, I think this is better. I know you slept well. I know you've had good breakfast, so certainly you are fine. Our rapporteur has just finished presenting what yesterday. And I think one or two things he might have skipped. So if anybody wants to add anything as a question or something, the floor is open. What I can say is we had only one panel discussion. We didn't have two. The second one is yet to be held. So I think that correction should be made. Okay, thank you. Right, there's a hand here. Sammy, and then there's another one there.
The presentation of awards, I don't know whether it was urgent.
I think that I should have indicated that this is not exhaustive.
Okay, but I still suggest that find a place somewhere and then insert it. Okay, thank you. Was a hand? Yes, please, back there.
Thank you very much. I think the regional minister was speaking to a collaboration between the regional health directorates and the DCs, so that they also become part of the half-year review, not just on accommodation. I think you made the right up purposefully for accommodation. Thank you.
Yeah. Dr. Chair, yeah, please, can we ask some questions? The regional minister's request, he was not aware that at the district level, the MMDCs attend review. So it was after the program that we alerted him on that. But then he still thinks that after they attend the district reviews, they should come to the bigger forum here and then also listen to what is happening here. So should we go by that, or we still allow the MMDCs to just function at the district level? That is what we have to decide on, agree on, and then start writing to the DCs that they have to come here. So let's take a decision. Thank you.
Right. That's about it. Our director will address it when it comes to the floor. Thank you. Any other concern, addition, things? On that note, then, thank you so much, Mr. Peter, and then you are discharged. But do it. Oh, but you are still a representative. Okay, Mr. Baka, thank you so much. You are discharged. At this point, we will listen to let's do it. Let's give her the hand, please. I don't want to believe that most of you are suffering from what I suffered from last year when I got to the coastal area, and then almost every day I was kind of cold. I was feeling cold and cold and cold. And I think you have been here for a long time. So let us give the regional director a big round of applause. Senior Director, the floor is yours.
Thank you very much, Dr. Chair. Good morning, everyone. So you are doing the same thing again. Good morning, everyone. Good morning. Thank you. On behalf of the Senior Management Committee, I thank you all very much for your active participation yesterday. Yesterday, we went beyond 6 p.m., even beyond 6:20. But you stayed with us, and you were active even at that time. And we say thank you. We know that it is out of passion, out of love, out of respect, and we don't take it for granted. So thank you very much. Also, we are saying thank you to all our invited guests, to all our speakers, moderators, chairpersons, panel members, the choir, and all who have assisted, even behind the scenes that you don't see, in making yesterday a success. And we also thank you in advance for today. So I want to first take a look at our agenda, if you have a copy. If you've lost it, we sent soft copies. So as our chairperson has already said, yesterday what we could not do was the second panel discussion following Dr. Yim's presentation on how networks of practice can facilitate our referrals and so on. So we will start with the panel discussion all around same. And after that, we will do our third expert presentation, which will be given by our own parent, on how we can manage our HR issues. And this one will also be followed by the third panel discussion, which is also around the HR issues in CHPS, networks of practice, and so going forward, so we can achieve universal health coverage. After that, we will go into our special reports. And the special reports all have the bearing on primary health care, on CHPS, on networks of practice, and on universal health coverage. So we shall have the first presentation on disability friendliness. We shall showcase what is being done in Gomwa West. I am sure most of you remember that when I stood here last year, May, I mentioned about disability. And we lost steam as a region, not because it was not on our focus, on our radar, but it was because we saw that headquarters wanted to do something about disability. And so we did not want to duplicate the effort. So we have been waiting on headquarters to do something about disability, and it's been over a year. So we are going back to where we started. Indeed, about 2-3 weeks ago, I was just about to share a Google form on our extended SMC platform for MedSups and district directors to do their own baseline assessment before the Gomwa West presentation today. But some things happened and I did not share the Google form. So we shall still listen to what Gomwa West has done. After this, maybe tomorrow or Monday, we shall share. Dr. Lee, you are training with me.
Yes. Oh, I see.
We shall share the Google form so that you do your own baseline assessment of where you are at in terms of disability friendliness. Please remember that if something is no, not existent, write it because it is your baseline. When you do the next assessment in 6 months or a year, what was no may turn to yes. There's no need saying that something exists when it does not exist. We really want to know where we are starting from. And also as a control, some people from other districts or region will select some of our facilities and DHDs and repeat the same assignment so that we know whether we actually got the truth as our true baseline. Indeed, when you look at our work in disability, you would think that we should focus more on our clients who are accessing our services. So yes, we shall do the assessments for health facilities, but we shall also do the assessment for health offices, the directorates, because among health workers and among people who collaborate with us, people who have something to do with us, or people who need our service, some people are living with disability and they must still be able to reach us. So if you look at our RHB, for example, if somebody is coming here with limited ability in any shape or form, you can see that apart from visiting the ground floor, they can't see any deputy director, they can't see the regional director unless I come downstairs. And there are so many other ways in which we have to look at how are we making our workplaces and offices accessible to persons with limited ability if we are talking about UHC, not leaving anyone behind. So remember that our assessments we shall do for offices, health offices, and we shall also do for the facility. For the health offices, some of the remedial action will be our own, but a lot will also depend on the local government authorities. And we need this one as evidence to make our case when we meet them with the regional director, the regional minister. So it is part of the things we are going to ask them to support us to do. So kindly note that. After the disability friendliness presentation, we shall have a presentation by Dr. Hannah Yorson from the health training institutions in Central Region. You know that they pass on their products to us. So we are in one continuum. They train for us and we use. It is the same reason why we have the medical school also represented on our regional health management team, and we also have the university hospitals and so on. Education and health are together, and so we don't leave them out in anything that we do. So they will also give us updates from the Coheti angle. We also are working closely with Mental Health Authority. Dr. Hatcher is here. He will also give us updates from the mental health. Because we said what? We are not leaving anyone behind. So we need to know what is also happening in that space. And then in March, when we're doing our 2025 annual performance review, 4 key things came up. We said we have to put NCDs on our radar. It is not just those who are coming to our OPD for the first time, but for those whom we are saying are having hypertension or diabetes and so on. How are we managing cases? So we should be looking at the end game. How many of these cases have become worse? So what are the consequences of the management of hypertension or diabetes that we have in our region? Apart from putting NCDs on the radar, we talked at length about referrals. I think yesterday Dr. Powell alluded to that fact. We talked about harnessing technology to make our work easier. So we're talking about teleconsultation, telemedicine, and last but after Mr. Koficha's presentation, it looked like in Central Region, men were dying more than women. And we could not explain why it was so. We couldn't say whether it was a data error or it was the true picture. If it is, then we need to understand why men are dying more than women, especially for us who are more committed in putting men's health on the radar. If men are dying more than women, what is making them die? Are they all doing that and say they are not the underground pits? What is making the men die? So we also put together a technical working group to look at the granular data to analyze mortality data in the region over some years, according to the age bands, according to gender, for us to see what is the real picture. So these were the 4 technical working groups that were birthed out of the important issues that from our first review meeting this year. And you know, review meetings are not for fun. We are supposed to learn something from it, and we are supposed to act on things that come up. So NCD dashboard, telemedicine, teleconsultation, the mortality data analysis, and the referrals. There are technical working groups here in this room who have been working on these, and we shall give them the floor to tell us what they have done. Please remember that we are doing all this within a limited space of time. So for all who are presenting today, we would ask you to keep it short and crisp. When we have our moments for question and answers, we would be able to give you the floor to add on when anybody needs further information. So please note this. Then we'll have our open forum. And one other thing that SMC has introduced this year is the area we call commitments and recommendations. Commitments and recommendations. We can't all travel from Diaso, Dunkwao, Kasua, and Bono East, wherever, and come here for 2 days and not make a commitment that we are going to do something differently. Then we should have stayed at home. Our 2 days here, all the discussions, all the speeches, all the comments coming from the floor must mean something. So there are identifiable groups here. We have those from the teaching hospital, the university hospitals. We have mental health. Dr. Kwao will join us later for leprosy and the skin NTDs. We have the district directors group, the medical superintendents group. We have COHETI. We have CHAG, private sector, ambulance service. There are so many groups here that I cannot call. We need these groups to make commitments. That's based on the discussions that we have had here. Looking at the ultimate, which is universal health coverage. Looking at our 3-pronged strategy, which is free primary health care, networks of practice, and CHPS. What are we going to do differently? Or what are we committing ourselves to fully to ensure that in the next 6 to 8 months, when we meet here, we can show the evidence, the data, that we have moved from A to B. So these are commitments we expect the leaderships or the representatives of these groups to make at the end of our meeting. And we also welcome recommendations based on our discussions here. You can say you recommend that RHD henceforth does ABC. You can recommend that Ghana Health Service henceforth does YZ. We have representation from council, from headquarters, from region. Everybody who can make this happen is here. So when you make those recommendations, we shall take what is ours and we shall ensure that those who are not here will also hear and do their part. So please, as you listen and you also think about all the things that we said yesterday, and also you have been working in the system, you are not new to this. Any commitment you think you need to make, any recommendation you think you need to make, please be ready to do that with us at the end of the day. And I will sum it up. So when you are doing those commitments and recommendations, I will not speak much because it is shared. Thank you very much for noting that. Then, please remember that for all our discussions yesterday, 2 things reigned supreme. Every presenter, every chairperson or was talking about data quality, and not just data quality, data use. Everything is data. So data for decision making is very important. Yesterday, we also remember that we heard about the geospatial mapping to be used with our DIMS2, to be used with the community scorecard. And we also heard, apart from the data, is community engagement. Community engagement when it comes to primary health care or the work that we do must start from the top. So we must do a lot with the local government authorities, we must do a lot with the traditional leaders, and it will trickle down to the basic community or our neighbors. And yesterday we all heard what the Honorable Regional Minister said. Indeed, we had asked him for a joint meeting between the FPHCs, the coordinating directors, the medical superintendents, the district directors, and SMC. And he gave us a date, but he could not honor that date. For the past how many weeks, we've been trying to get his attention so that we also update him on the things that are happening here that he needs to step in. It's been quite difficult. But now that he has come up again saying that he wants a meeting with the DCEs, our wish is not only the DCEs, and that is what we are doing here, and I am sure that will happen. So it will happen on his turf at RCC. Once he tells us the date, we shall communicate to extended SMC, and he will also communicate to local government apparatus. So we shall have that meeting. But what is important is not the date of the meeting. What is most important is for every district to show evidence. It can't be anecdotal. We are going to make a case, and the case must be. So you need the NIMS2 data to make useful graphs that you can use for advocacy. So it is not science, but something simple so that they can look at it and see, oh, this part we are not doing well. AAK. Or, oh, it shows clearly that this part we are not doing well. It is not only the NIMS2 data, but the geospatial. So like Dr. Yim was saying yesterday, post people to X when the need is in Y. So let them know where you need them to support you and show that evidence using the mapping system. And we also use the community scorecard to show them the feedback from the community and what we need them to do for us. So I said it is not anecdotal, we must have the evidence per district. So work with your hospital teams and make sure that when you are giving the slot in that engagement, you can use that data to make the case when we meet these people. So please note it. Thank you very much. Also, based on what we are discussing in CHPS and community scorecard, free primary healthcare in general, and so on, we are going to use our leadership huddle to bridge the gap in knowledge and understanding in these areas. And we have committed presenters who are here in this room, but may be in other regions, who also support us to do this. So ensure that all your team members join these meetings when we schedule them. They will be more purposeful, and it is for what we have decided to do. So don't miss out. I've already spoken about the disability, so we'll continue to be more purposeful about the school health. And it is very gratifying to know that now we can credential them, because previously we were not allowed to credential them. Now that we know we can credential them, then they can be real spokes to the hubs, and it is going to make life easier for us. And I think that we'll have lots of success stories to tell. So we shall also give more guidance on that going forward. Okay, so I will stop here and hand over to the chair. Thank you very much for your attention. I wish us all a good day.
Thank you very much, our able regional director of Health Service Central. Dr. Jarebu, are you around? Please come. Not be scared though. Sit over there. We are accelerating between point A and point B. But what should be at 20 kilometers per hour? Should be at 40? Should be at 60, 80, 100? The optimal one for most of you. But for you to accelerate, then you know that your brake pads are good. Your engine is not overheating. Your seat belts are well in place. And so we began yesterday. Your tires are very good. And we began yesterday when we discussed making free primary health care real. So we are ensuring that our human resources is good, our funding status, our financing is good, and so we are continuing from today's to today's network of practice as the engine for universal health coverage, coordination, referrals, and accountability at the district level. To help us, we have panel. Dr. John Daxi. John, are you here? Yeah, please let me to him. John is the medical superintendent for Elmina Government Hospital. He calls his hospital a baby hospital. John, please come and sit. Then our own Dr. Samuel Oposu. Samuel, Yes, please come. So somebody the Minister of Health Service, Cape Coast. So we are in his jurisdiction. Right, Sammy, thank you. And then, hey, my own madam, Agnes, Dr. Agnes Eshiama Anane. So Dr. Anane is our Deputy Director, Clinical Care. Right, thank you. Then we have Mrs. Alice Edu, National Ambulance Service. Alice, are you here? Mrs. Edu. Okay, let's give her some few time. I'm sure she'll join us. Then Mr. Robert Awudi, Central Regional Chairman, Private Health Facilities Association of Ghana. Robert, are you here?
No, I think he's ill, so he cannot make it. He has someone to come, the person. Mr. Audi is not fine.
Okay.
Then he has someone to come from Asinfo, so the person who said he could not make it. So we.
Right. Right. You still make do with what we have. John, over to you.
Thank you very much. Good morning. So, thank you very much, Regional Director. Thank you very much, Dr. Chair, for this opportunity. This was like a chief examiner examining the students. Okay. So, we zoom into, okay, let me give a background. So, the universal health coverage requires a strong system that enables equitable access, quality, and financial protection. So in Ghana, the network of practice approach has emerged as a key strategy to strengthen the primary health care delivery by linking the community-based health planning and services, that's the CHPS concept, the health centers and the district hospitals into functioning networks. NOPs aim to improve the condition, streamline referrals, and optimize resource use. But in Central Region, early experiences have shown that the NOPs can enhance collaboration among facilities, reduce duplication, and improve patient outcome. However, challenges remain in institutionalization, accountability mechanisms, enhancing effective pathways, and sustaining coordination across diverse districts. So the panel discussed to explore how NOPs can survive in the engine, as the engine for universal health coverage in the district level. So let me start with you, Dr. Ofosu. In what way we are looking at the coordination of NOPs? In what way practical steps can district take to strengthen the coordination among CHPS, health centers, and hospitals within the NOPs?
Thank you so much, moderator. As we are all aware, the whole of the network of practice cannot be achieved when facilities work independently. So the idea is to bring all the facilities together within a geographical place. So in making sure that facilities are well coordinated and contributing to the universal health coverage. One, every district, just as administrative, we have the sub-districts, sub-networks, and other things. We should have a miniature of it. That's the networks. We have to establish our networks. And within these networks, we should be able to define the services that every network is supposed to provide. And after establishing these baselines, we need to measure the performance on monthly basis. What are we doing? If what are we doing? We have to report on what we are doing within the network. And since the network comprises of a hospital, health center, polyclinics, CHPS, there's the need for the network to have a joint supervision, in that those experts within the networks, being it a specialist care, public health, whatever, there should be that kind of coordination. We should have those joint supervision to ensure that the activities are well streamlined. And moreover, within the network, we should define a clear role of our referrals. How are we referring? Is it from the CHPS straight hospital? Is it from the hospital through to the health center? We should define all these in order for us to know that this network is really functioning. So in summary, we should establish the network. We should have defined the service that the network be provided. We should have reviews, monthly reviews on the activities done, and there should be joint monitoring and supervision schedule within the network.
Thank you very much.
Hello, sorry, Minister, before you go on. So we have just been joined by Mrs. Alice A2. Mrs. Alice, the National Ambulance Service. Ma'am, welcome. Please.
Thank you very much, Dr. Chair. So my next question goes to Dr. Tazi. In what ways can NOPs help district staff, equipment, ambulances, and specialists to improve their efficiency under the resource constraint?
Okay, thank you very much. Network of practice, the idea behind it is to ensure that facilities are not working in silos. I mean, they are not working on their own. And then we also know that most facilities have resource constraints. Most facilities have staff deficits at all levels, right from teaching hospitals to the CHPS. And so one of the aims of objectives of the NOP is to ensure that we mobilize resources within every network and ensure that those resources, both material and human resources, are being used to the benefit of the patient. And so, for example, where I am as a medical superintendent, I have a network with a WhatsApp platform where every in charge of every CHPS compound or facility has my contact. And so they can call at any time. We have a WhatsApp platform. If I'm not reachable or if any other place is not, any unit or any section of the hospital is not reachable, whether obstetric emergency or the medical emergency, they put a message on the WhatsApp platform. There are other doctors there who can't respond to anything. Now, in a situation where you pick an obstetric emergency, for example, and then even though one is reachable, you put the message there. Someone can even call you, okay, let's our ambulance, if you are having challenges with securing transport, we can send our ambulance to come and pick the patient. For such situation, you may not have a readily available ambulance. Maybe the National Ambulance Service is not available at the time because almost every district has one. And so at every point in time, someone will be using it. And even sometimes when it is available, they may lack oxygen. There are times that we have told them that even though you have the ambulance, you don't have oxygen, come. We have oxygen cylinder. We have it is filled. Can you come for our cylinder so that the patient can get the transport and the quality transport systems? And so at that point, we may have the ambulance, the CHPS compound does not have, the health center does not have. We have worked together in a more coordinated fashion to be able to transport that patient. For example, in my former network, I received a call from a community health nurse who is not doing deliveries, who is not doing anything. She put in a call that she had called that someone has delivered in the house, so she's going. So I asked a simple question. Are you going with cannula? Are you going with any medical item? He said no. But you have to walk about 20 minutes to get there. And they've told you that this one has delivered in the house and is bleeding. No access to transport. You have to walk there. Why don't you just pick some few items that when you get there, you can even put in a cannula, start some IV fluids. If the circulation of that change functional until help comes. And then send our nurse manager and a big wife with, because we are in our little base, not even though it is seen as relatively as very remote, but compared to where she is, we are in town. And so we send Pragia to help a midwife who can remove the placenta and make sure that this woman is sustained. So she went back to the CHPS compound, picked all these items. So by the time our people got there, she has set a line. One of the coordination is to provide her with that knowledge that you cannot just walk to that place and go and watch on and keep calling us. No. And then eventually help came. She got to us. Our lab was ready. There was about 2 units of blood ready. And so you could see that just one person's ability to coordinate all of us. I didn't go there. I coordinated all of them to ensure that that woman did not die in her room, even though we are not expecting her to deliver in the house. So one of the ways of coordinating is to use telecommunication, use WhatsApp platforms. In the moment you place a PPH on a platform, the lab in charge is there. They have all been trained that this is the NOP system we are running. You have a responsibility. I have a responsibility. So one of the ways of coordinating and ensuring that we also harness all resources is to, for especially the medical superintendent who are usually in charge of clinical care in the district, to take ownership of some of these things and coordinate using some of the available laid down systems we already have to harness the coordination for us to get the result that we want in the NOP system. Thank you.
Thank you very much for that. Practical. So you've been mentioning a lot about the referral system, and which is a very big component part of the NOP system as well. And for those who have been doing a lot of the referrals, helping us to transport patients from one end to the other at the national office. Madam, you're welcome. So I want to ask, what are the current bottlenecks in the referral system, and how can NOPs help address them, the network of practice?
Okay, thank you very much. If you want to talk about challenges that we are facing, there are many, but currently we are faced with inadequate ambulances. And then we also have poor road networks. And sometimes before the hospitals will call the ambulance, the patient condition had already deteriorated. So they also don't call early. And so by the time the ambulance will move from one district to the other, the condition is already getting worse. And sometimes too, they don't provide the right information to the ambulance dispatches. For example, patients may be on oxygen, but because of one or two reasons, because they want the patient to be moved quickly to the next level of care. They won't give us the details. They will just describe the patient as normal patient. And then we'll get to the scene and realize that no, this patient needs a critical care. And in ambulance, we have levels of care that we provide. We have the advanced and then the basic. So if you tell us what is really happening to the patient, instead of maybe dispatching the nearest ambulance, we rather dispatch the one from far distance who can have an EMT who can take care of the patient. So they don't give us the right information. You come to the facility and then the patient will be on oxygen, but the ambulance will come because you didn't tell us it's on oxygen. Will come with an ambulance that is empty or have oxygen. And then when it happens like that, we have to negotiate with the hospitals. Can get us a mobile oxygen? Them too, they don't have. And so we'll be battling with oxygen and other things. By the time our people give us the information and then we call another ambulance, the condition has already gone worse. And so these are the challenges. So we entreat with the facilities to kind of give us the right information. And I also expect that a network of practice will help us provide a standardized referral protocols. And these protocols should be clearly defined to all the health facilities, that is from the CHPS, the health centers, to the district hospitals, so that they will follow clearly what they are supposed to do to avoid this kind of problems. Thank you.
Thank you very much. So, last review, we realized that you had only 12 ambulances.
Yes.
So, what is the current situation now?
Currently, we have 11. Currently, we have 11. As we are talking now, from Kaswa up to Apam, the vehicles are not working. So we are relying on, in the metro we have 4, and all the 4 are, 3 is not that, is only working within the metro, but the 1 is working within the metro, but the other 3 can go to other districts. So these are the ways we are managing. So when there's a patient at trauma and they call, we normally ask one from Ankesim or Cape Coast or Abrodumba. Abrodumba is functioning, so then they go there to assess. And then if the patient is at Kaswa, when you call the dispatch center, we negotiate with Greater Accra to come and help. But with Dunkwa or Fen to Praso, Dunkwa ambulance is not functioning, but Diaso is functioning, so we rely on Diaso to support Dunkwa. And then the 3 are since 2 are not functioning, 1 is functioning. And so we also rely on the other one to take care of the rest. Chupraso is currently working. Chufunyamai is also working. So the down there, because of the pressure, Kaswa is highly populated and they are always and then Winnipeg was one of the busiest ambulances that we had in the region. And so because of the pressure that they are always responding to RTAs and other things. So because of the pressure and a poor road network, especially in Sabai and Ku, the road is very bad, and because of that, they are always having breakdowns. But when you come up here, our road networks are somehow okay, and that is keeping the vehicles in good condition.
Thank you very much. We've been talking about that. So, yesterday and today, and even it was added for the regional health director about data. Data is an issue, and I want to ask EDCC, how can data and digital tools be leveraged to improve coordination and decision making?
Thank you so much. So for Central Region, we are already using the telemedicine when it comes to maternal health. And I must say that some of our zones are really doing well with the maternal health platform, as it has been elaborated by Dr. Dazi. We can't leverage more because it's more like now it's only maternal health that we are actually working on. But then we have to also ensure that we can expand that telemedicine to other areas. We started with, we have a committee that is working on telemedicine, and definitely when that committee is done and we are able to have a telemedicine at trauma center, it will help us. Trauma and specialist hospital is going to really help us because we know that down there people may have cases that they may not know that they may not have the technical know-how to handle those cases. They may not even have equipment. Currently, in the advanced countries, they are doing a lot, they are exploring a lot. People can sit in their home, people can sit in their offices and even manage cases in the very lower facility. Yesterday, I watched a documentary whereby even dialysis was actually operationalized from a hospital to a client who was in a lower facility. With our poor networks and with roads, I think this is the way we have to actually go by using telemedicine. Now for us, we don't even have a pediatrician with Ghana Health Service. Our pediatricians are at a teaching hospital. So if you have a very bad case in a lower facility, whereby even the referral to CCT is difficult, definitely we have to have that means to be able to manage cases at that level. This will be at the regional level, but then when we did our district, what can we do to ensure that we are able to the needs of our patients, our clients at that lower facility? We are supposed to use that same network, but then aside that, what we can do is aside the WhatsApp group, we can actually put to ensure that we are able to do that. When it comes to data, unfortunately, some of the markets are not abreast, even with they are not interested in data that is generated within their facility. They are not interested because sometimes something can happen, you can have information, then you call to find out, and the medical soup or the district director may not even be aware of that particular data that you are asking for. Meanwhile, that data was generated from that facility. So we have to be interested in data within our facility. If you are interested in the data, that is when you know the issues or the challenges are. Let me give a typical example. For instance, maternal mortality happens within the district, and this mortality was from a maternity home. If the district is not aware that we have this maternity home that gives us this maternal mortality, definitely your workings, your supportive supervision, everything that you'll be doing, you will sideline those people. But then for a network to actually happen, for us to have a successful network within our district, we have to ensure that the data that we generate, we should be passionate about the data. If you're not passionate about the data, things will happen within the district, but it will not even be reported. We have to ask for those data. We have to be intentional about it. We have to ensure that the network brings on board the traditional healers, the faith healers, everybody, the chemical sellers, because no matter they are the first point of call for some of us. And there's another that sometimes if you've not experienced, you don't even know where healthcare workers, we even find ourselves when we are in that similar situation. So we have to ensure that we generate data from all these points of service. So when we are making a decision for the district, we will know the gaps and we will know what we will be able to do for a particular district. The data that you generate varies. Some community, it may be different, or some districts, it may be different from the other. In that same way, the approaches will also differ. So you have to know your district very well, then you know how you'll be able to generate your data. When you generate that data, then you know how you'll be able to use your telemedicine to address those data. Thank you.
Thank you very much. That's well spoken. Let's look at issues about accountability. It's very important because government is bringing the money, they are building the infrastructure, they are bringing ambulances, whether it's the small one, they call the truck for trachea ambulance or the bigger ones, whichever one. But a lot of resources are going to be put into this free primary health care. Go a long way to help the network of taxes and so on, so that we can achieve the universal health coverage. However, accountability is also on our side as practitioners. So let me come to you, Dr. Daze. What accountability mechanisms are most effective in ensuring that NOPs are delivering their mandates? I mean, the NOPs deliver their mandates.
Okay, thank you very much. So for accountability at the district level, maybe having our medical superintendents on that don't put that area too much, so it becomes very difficult. But at least the community health committee can hold the leaders of the NOP accountable. And once they have ownership of the NOP, they will be concerned about an ambulance, a tricycle, or even a motorbike that has been given to them. And then they will be accountable. They will also ensure that if drugs have been given to the people, but they don't have access, they will give the and ensure that the health professionals are accountable to every resource that is given to them. And then also at the sub-district and the district level, once I'm a clinician, I would want to speak with clinical meetings. It's a form of having accountability, because if you have clinical meetings with maybe the physician assistant, my facility, I do that. I remember last year when I had a training session for cardiovascular disease, where all the physician assistants in charge of the service were present. At a meeting, one of them said that we have been practicing this one, we don't know it has changed. So you could see that just that information is going home with. There are some hypertensive cases we manage better than the way, and that will reduce the cases. It's like avoidable referrals. As referrals, they are actually avoidable. Bringing them to the hospital when you are wasting the time, you're also wasting other patients who need the care time. So those ones could be avoidable. Just by having clinical meetings, community members, and other things to get feedback from people and also impact knowledge. So accountability at the district level to one of the ways is to move from maybe supervision to stewardship, that we should be able to own the thing. It's not that at the district level, the district director and the program managers, they should go there. And for me, whenever I'm going for NOP visitations, like quarterly visitations, I go with the nurse manager, I go with the administrator, so that the administrator will also supervise their procurement practices. And then the accountant, I think the last time we went, accountant was able to waste and revenue look into their books. And then you realize that but if you say more people came, that your submitted is this, what happened? And you could see that question alone, I didn't look at those things. I was just going to look at whether there are cases that seen evidence. But bringing the accountant in during the quarterly visitations, also have technical people at that level. And so for me as a medical superintendent, we should be able to also use our management members to go down and provide support for them and make sure that whatever is being given to them, either through free primary health care, they are accounting for it. There are times too that in your visit, you should go with, I know there is a tool that we use for the visitations. When you go, you have a checklist. And so using the checklist, and make them accountable. You go there, emergency drugs you are supposed to have. You ask them, do you have it? They say, we don't have it. Then you meet the manager and ask, oh, we gave them 10. So why don't they have? Because that has happened before where we went in. The manager is, oh, just a month ago, we gave it to them. So how can they just get finished like that? And then you add the number of deliveries. We have given you 10 vials. We have done only 3 deliveries, and they are all gone. There is no major complication. Where are the rest? Either they are not reporting even their deliveries because going to their pocket. So you look for reasons why some of these data that they even churn out is happening. And so what I would say is that with the accountability, community should make sure that the people are accountable. And then the leaders at the sub-district level, at the district level, and at the hospital, the clinic level, also ensure that all these people, and we must bring in the other technical areas, like the accountants, like the procurement officer, like administrators, and even the nurse managers, to also ensure that these people are accounting to us whatever knowledge resources we have given to them, whatever material resources that have been given to them. And not only that, the district level, like I said, the people should go to the place. I was in a district. I can say that I visited the chief's compound more than the district director. I'm just being frank. Me as a medical student, I visited and one of the concerns was that when are we seeing our director? When are we seeing our director? So me, I'll just say when the director comes, ask him. Because I cannot tell. And so for me, I have come. It is my responsibility. I have come. Because now when they share the money, I don't get some. But at least I have come. And so that's one of the things. And the other thing is for the medical superintendent to budget for these things. Because if it is not part of your annual budget, you cannot spend. You understand? And that's also one of the ways we can. If it's in your budget that you are going to go quarterly visitation and supervise or coordinate some activities, then it will be part. And so every quarter you move with your team. If this quarter you go with 2 different groups, the next quarter you go with another group. And facilities in districts where there are more than 2 hospitals, like my district, maybe we can alternate. Dr. Pao and I can alternate, but because he's my senior colleague, he should go more than I should go, so that at least also learn from him. So I think we should make it more practical and take ownership of the thing, because if we don't do it, the pressure keeps coming to us. So on the accountability, I think this is how we should go. The outreaches, the quarterly meetings, the clinical meetings, the committee of committee meetings, not that you go to the network. Oh, yeah, it's book committee of committee meeting. So who is going to account people? Why are you going to tell them your problems? And these are all requirements in the checklist. And so we should go in that direction. Thank you.
And that's wonderful. And I think apart from being on the budget, it should be part of our objectives to appraise so that we can act on it as well. So talking about the community, like I want to come to you, Dr. Fusu, who you have been a district now a district director for a long time. How can communities be engaged to hold health facilities accountable within the communities?
Thank you so much, moderator. One thing that we should all be aware of is that communities are not only sharing the services that we provide. they are co-owners of the health system. So anything that we do, we should always have them in mind. We've spoken about CHPS. The concept is about community-based health planning. So we plan with the community, and when you plan together, at least you should also assess yourselves together. So we've had some initiatives. One, having a community DEBA is one of the ways you can account to the community. Sometimes they want to know what is happening in the communities. We've had situations whereby communities members will move to the district demanding for the services rendered. Sometimes they want monetary value. How much are you generating? How are you spending it? Especially when you go to them with some request of maybe renovation, a request of painting and other things. So through community DEBA, we can account to them. And the initiative of the community scorecard, we come to you every day. You enjoy the services that we have. So tell us, how satisfied are you when you come to our facilities? So the community scorecard gives the opportunity to the community to assess the health services. And something that we've all stopped doing as part of the review, hospitals were assessed, these were assessed on the operational research, like the health satisfaction survey, community or client satisfaction survey. Those were some of the things. If communities are not satisfied, they will show you through the survey that you conduct. So we have to bring it back for them to be able to assess us and to assess the services that we provide to them. And also, during our performance reviews at the district level, at the sub-district levels, we do invite stakeholders. Sometimes it is an eye-opener. Sometimes they may have maybe a small view of what is happening within the whole network. But when they are invited to join reviews as this, they will get to understand various fragmented issues within the networks. So by using the scorecard, by using the community health committee, by organizing client satisfaction survey, it is a way of the community assessing the services that we provide.
Thank you very much. Now let's look at cross-cutting. So let me come to you. What role should the Regional Health Directorate play in the socialization of the NOPs? The role should the Regional Health Directorate in the socialization of the NOPs?
Thank you so much. So what currently we are doing is one, to ensure that every district so Central Region we're given 29 NOP centers, and for that one, what we've done was to ensure that at least all the NOP centers have been launched, which were done in about 2 or 3 years ago. But then for the checklist for the NOP centers are supposed to mature, and it comes with a checklist. Some of the things that we are doing, one is to ensure that at least the NOP centers have the requisite staff to work with. Even though some of them we really do have challenges, especially when it comes to some cases like pharmacy technician, lab personnel, and the car staff like account officers and the rest. And that is what at the regional level we are lobbying to get these staff to be at the NOP centers so that we can actually help the centers to function. The other thing is about where they are currently operating. Some of them, we have issues with security. For the NOPs, we are to ensure that the services is run for 24 hours. So one is also we are collaborating with the DCEs through the regional minister to ensure that the DCEs are able to provide some security for these health centers that we are using as the hub. Some of them we were able to get the community members, but then if you get community members performing the role of security, some of them initially were free, but now they are demanding for some financial support, whereby the facility is not able to provide, they actually withdraw their services. So we are still in touch with the DCs to ensure that at least we get some security personnel so that our staff can actually run the 24 hours. The one key challenge that we are also facing is the accommodation for staff, because for the health centers that are supposed to run the 24-hour service, we are supposed to house them so they don't move from one end where they are lodged to the place. It's quite unfortunate that even where the districts where we find we are operating at NOP, we do not get accommodation for staff. You can actually put the district directors are here, they can attest to that. You can put somebody there and it can take a month or two before the person can get accommodation. Some time back, DJ asked that we present land around the health centers. We took that data from the district to DG, and we are hoping that at least some accommodation will be provided around the health centers that are operating. The other thing is that we are trying to bring on board all the stakeholders and trying to start that or operate it from the regional level. Operating the NOP centers, especially where we have the centers in between two towns, it becomes a challenge. That was the initial stages. Who owns it? What will be the name? So we have to actually bring everybody on board to ensure that they accept it. If you have an NOP center and it's not accepted by the two communities or the communities around it, it becomes non-functional. We give a typical example. We invested one facility, it's an NOP center, a health center, and that community, they have chieftaincy issues. So we entered and people were standing, there were chairs. So we asked, why are people standing and they are not seated? Apparently the chairs were brought by a section of the chief, and those who came that they won't sit on that chair. So it tells you that if you don't bring everybody on board, it becomes a challenge. So that is what during the launch of the NOPs, we ensure that all the chiefs, they actually understand the essence of the NOP. And it's not just that, my previous delivery, I mentioned that we need to bring the traditional leaders and the other people on board so that we'll be able, and that is what at the region we ensure that the private sectors, we are now trying to group in the traditional healers so that at least when we want to have a very functional one, we'll be able to have it. Thank you.
Thank you very much for being very answer. So, because of time, bring to an end of the panel discussion. Let's look at it. Fixing the referral system. I know the ambulance system really challenged. We pray that government will come to aid to make sure that we have the logistics and the equipment to help the NPs to transport our patients. We also look at the use of the telemedicine, data, WhatsApp, and other platforms to make sure communication and decision making becomes very effective. Sharing resources together as facilities as well. Teamwork, that's building up the links. So Dr. Dazi said something about the clinicians also going to the field in terms of supervision as well. And looking at the community engagement, it, as Dr. Fosun has mentioned about it, we should let the community take ownership and help us to render services and accountability as well. And facilities also, I think they should also have means of transport. It's about time our facilities should have some ambulances. Not only the national ambulance, our own ambulances as well, to move patients to referring centers, so they can influence the management. And also looking at the staff in terms of accommodation, incentives, motivation. Our staff be telling us we want motivation. I come when I come to them, say we have to look at that one too, because a hungry man is a hungry man. So security is becoming an issue in our facilities as well. So thank you so much, my good panelists, for your kind words and knowledge you have shared with us. Back to you, Dr. Chair.
Yes, I hope you are not by any means discharging them because their work is not yet done. We will open the floor both in-house and then online. We appreciate those online. We acknowledge your presence there. So if anybody wants to ask a question, yes. Those online, if they want to ask questions, it's okay. Chat. So the floor is maybe 2 or 3 questions and then we are out of here. Okay. One there. Another.
Okay, good. So thank you for the opportunity. And then I congratulate the panelists for good work done. Yesterday, the keynote speaker said, if you fail to supervise 8%, you fail in delivery 90%. I hope you all remember. Yeah, during the recent harmonized health facility assessment, part of the results said that when they went to the field, some of the people in the chiefs said a whole year, 2 years, this director did not visit. I'm just backing John's, Dr. Adazi's comment. Yeah, so it's on record that some chiefs, 1 year, 2 years, no visit by the district director. So if we don't go, then we don't get the results. If you fail to supervise 80%, you fail 90%. So I just want to appeal again to our district directors that supervision is very, very important to achieve results. Thank you.
Thank you, DDA. Right.
All right. We the panelists for good job executed. I'm Jason Kobola, Abrantes Chum, associate with Castle Polyclinic. My question, let me put it this way. My comments will be directed to the National Ambulance Service because I strongly believe it's a very vital tool if we really want NOP via UCH to accomplish the cost target. Last year, we had 11 or 12 active ambulances.
Last month.
Last month. Now we have 11. By projection, I'm thinking that by the end of the year we should have like 4. Why do I say so? We have, as an administrator, we believe that you try to do things more in a proactive manner. And what do I mean by that? We have what we term as our planned preventive maintenance schedules that are in place. The ambulance is a special purpose vehicle. One, I have problem when mention was made that except you are prompted that the person is on oxygen, carry an oxygen. I don't know when I heard you well, but an all-purpose vehicle meant for an emergency service need to have everything in there, regardless, because the person can be stable on transit, on management, the person might need oxygen. So I think I don't know whether that's what you said, if you can bring clarity to that. And second to that, we should have a sustainability drive. one of the panelists made mention of that. It is non-functional. Non-functional. Me personally, I see non-functional to not to be a word to adapt. Why? Non-functional, is it engines not working? Are they just related to ties? Are they just related to electrical systems? I think we should get to understand the non-functional bit, because I'm privy to the fact that there's some non-functional ambulances due to some of them don't have ties to work on. Yes, that is a fact. So those ones that out of the way, that could be resolved, because I know that the district assembly municipal MDCs have been empowered to focus on health-related actions. So getting 4 ties for an ambulance and all that, I think the MCE should be capable of doing that. It has to do with your lower amber or whatever, or link bars not working. That can be fixed. So, madam, I would much prefer, statistically, when you come here, let your non-functionality be more comprehensive. Then we can also appreciate and understand how deep your problem is. Thank you very much.
Okay, so I think your point is well made. Yes, Dr. Yim is here. Okay, madam. Yeah.
Yeah, please, my name is Kwame Mofa. I just want to add up to what Abrante just said. The issue about NOPI, I actually understand that improving the referral system or the referral pathway, but has there been any way where if the non-functionality of the ambulance service, we then bring on board the transport union to support the service? Because in a situation whereby the ambulance is not serviced, it's mandate. How then can't we improve on the other transport union to also, in one way or the other, fit in the same? Because not all conditions will demand oxygen. So in terms of conditions that are not demand oxygen, and we don't have the ambulance service in place, couldn't we then transport the patient to the referral center for continuum of care? I just want to also find out. Thank you.
Okay, thank you. Dr. Ayim's hand is up here.
Yeah, I just wanted to make a point on motivation. And one of the critical things in the NOP put on motivation was a good leader, just a good leader. You know, bad leaders demotivate staff badly. In fact, I remember when we used to work with a director at BPN. There was a day she traveled, we were in a meeting in Ufrodia, and it was near Christmas or something. And the director traveled all the way and came to give us flowers or something. And we still talk about it till it was 8 years. And we still talk about it today as workers. I hope you are getting the point. So sometimes you are, when you have a good leader, but some of us are so bad that the leadership is so bad, just a good morning and your response is so bad. So I'm not talking about all the financial motivations, but I'm saying that a lot of workers are insisting on just having a nice leader and a good leader. And I think once we put that into the LOP, where we know we are leaders. So that's why the rules, when it comes to the rules of supervisors and all those things, just being good as a will start the motivation. Then later all the other things come from. Thank you, sir.
Thank you. Then we need more cake over here. Thank you very much. Who is talking?
Yeah, thank you very much. My concern is about the district director's office. It's a very simple. In fact, I'm going to personally talk to the DG and do something about it. Is it people started to get this office and they go there to not work? Now we the district director and you won't go and visit. That is serious. I think that we should have to come up with some procedure. Again, we can assess the district directors, where we can get feedback from the chief compound. At least they should be able to communicate to us about their district directors, to assess them. And that will also help. Because district directors are not serious. I think those district directors need to be. But otherwise, it will affect the system. They are just there being business. They are not there to work. So this one is serious, and I think we should work on it as early as possible. The other thing is how to do the security. You see, as health workers, we are not trained in security. At the level of the districts and then the health compound, if the security should be in the hands of the district security, then we have to write to them and let them notice their role. You are supposed to provide security for this, or we are requesting for you to provide security for this. If they don't do it, the next time we are writing to them again, reminding them by copying the minister, the regional minister, for them to know that this is what they are supposed to do, because they are supposed to provide security for the place. It's not our job. So, for me, we should take action on that. The other thing is about the generally, I think we need to all try as much as we can to push for things to be done. Okay. Because we can't go take the position and just go right there and you are not doing anything. People are struggling, lobbying for positions and they don't want to work. So why should you go there? I think I'm done. I'm supposed to say thank you very much.
Only two more and then we bring it to a close. So two, yes, you and then right, okay.
I'm Jonathan. I wanted to make a contribution about the community engagement. I think yesterday it came up about patients refusing referral and there are reasons to that. And I think one thing we're not doing right is not letting them explain, not explaining to them the reason for referral to the patient before it happens. I think it should be part of our community engagement when we meet them. That you are being managed here at a point in case there's a need for you to go on referral. You have to go for the referrals for your own good. Personally, my research was on emergency referrals. Then I interviewed some of the nurses. Some of the reasons the clients will give for not going for the referral, one would be, of course, financial issues. Because at a higher facility, they are going to pay more. The other issues too was going to be about the fear of death. Growing up, you all knew if you go to Konibu, it's more likely you are going to die. It was after I entered Konibu, I realized that it's actually one of the best facilities in the hospital. So people have that mentality that if you are being referred to a higher facility, the likelihood of you dying is more. Okay. And most of the news we hear on the media are bad ones.
Yes, I think your point is well.
The last point I also to make is yesterday there was a point that was made that if there's something we don't measure, we will never know whether we are doing well or not. We're talking about referrals, and we are probably not measuring what we are doing. Most of the CHPS compound I listed last year didn't have a referral register. So they are not even documenting the referrals that they are doing. We are not getting feedbacks from the higher facilities as to how the referrals are going. And if we don't have this data, we can't actually make any informed decision. So I think we should work on our data.
Right. Thank you so much. The last one, I think we.
Thank you very much. My name is Dr. Akol Daniel, and I want to take this opportunity to address a particular issue with the ambulance.
Please go on.
So, for example, in Upper Dentra East, we are doing a lot of proposals in collaboration with the Municipal Assembly, and very soon we'll have to report to the Regional Director of Health Services for some cover letters because the proposals we are writing are international standard and we need the support of higher levels. That is one. The other is the issue of ambulance. And so, Napa they try several times. Sometimes we even level the paramedic agencies to actually address the issue, but there's a gap. And the gap is actually has to do with policy. So going forward, I'm thinking probably at the regional level, the national level, what can we do? For right now, the main problem that ambulance at Tapa is an engine problem, which the cost is really that high. We don't really have that money right now. But I think going forward, if we do stakeholder analysis and we can see where all of us, our work interface with the ambulance service, and then come up with a policy. Okay, as part of our budget, we should allocate this more, and when it breaks down, we can be used to fix it. And then collaboration with the ambulance service, we see how we can also use that as a revolving fund. Then we are actually solving the problem, because other than that, it's not bringing us together, interfacing with one another on how to actually provide funding for the ambulance service. And
sorry, are you proposing that key stakeholders to come and then make a fund for the ambulance? Is that what you are proposing?
Yes, so I'm saying that we have policies and we have stakeholders. So as a framework, maybe in every district, when we look at the stakeholders, we levy a little bit, and then it's the fund that can be there to solve the ambulance problem. And then the ambulance service also, you leverage on that as a revolving fund. Because there are some of the issues, when you talk, they're saying this one at the national level, they're saying they should wait for them and then they will get back to them. And it's taking so many months and the problem is not being solved.
Okay.
Like the engine problem with the ambulance service about the Chinese.
It will be taken up by the regional director. Thank you so much. I think that brings us to the end of our the discussion forum. Okay, so now the panel, if there's one or two things you want to, then we give ourselves 2 minutes to do that. Short.
Very short. I want to make a suggestion. I usually don't make recommendations that I don't have control over. So to medical superintendents that are here, I'm a junior colleague, I have senior colleagues, I have colleagues who are at my level. I want to say that if you meet a facility with an ambulance, try as much as possible to function. Because my facility, I met an ambulance that will function. I've put in every effort to make sure it is functional. And it has helped me. If I have a critical case, I've struggled to get receiving end to take. And even at my oxygen, there is no proper oxygen cylinder, the driver is not trained. But once we have them tell us that you can come, we carry the person, put the oxygen, the mobile oxygen in there. We transport them, case closed. It's also a form of generating revenue. So the point is, if there's a functional ambulance, let's maintain it, because we may not have but the ambulance.
Okay.
Yeah, thank you very much. I want to clarify something here. We wanted to know if the patient is on oxygen before we come or before we carry oxygen. I want to clarify it. It's not that we want to know before we carry oxygen. The oxygen cylinders in the ambulance, all of us know that it's not as big as it's a normal size that we can put in the ambulance. And we have two. So if maybe in the morning we have a platform that we report availability, which includes the oxygen, the equipment that we have in the ambulance, whether they are functioning or not, and even the staff, the staff that we have, whether they are basic or we have advanced on board. So all this information that we get from the station help us to know the ones that we should dispatch according to the case that we receive from the facilities. And so they may be having full cylinder, full of oxygen, but along the way, they may be dispatched to go for emergency, they will use that oxygen. And then the moment they arrive at base, the same facility will call for the services. At that moment, we only have a regional center that will keep the field oxygen. So if they are empty, then we have to send field one to the station. And so if they come and there's another case, and you don't tell us that the patient is on oxygen, we may decide to dispatch the nearest ambulance, but that one may not be appropriate for the patient. Because if, for example, Edumako Hospital is requesting for an ambulance and Edumako is available, we will dispatch Edumako, but it may happen that at that moment they don't have oxygen. But we can call for Mankesim.
Okay, so I think your point is well made. When they are dispatching the ambulance, there are a number of things they look out for, and your information will help them to decide. The oxygen as a commodity is just one of them, the human resource. So if it's an advanced case, then they will know which ambulance or which human personnel to dispatch. I think the point is valid. Okay, thank you.
You also wanted to know the kind of problems that we have with the ambulances, if it is engine, if it is injectors. The engine is very expensive. And Kaswa, for instance, recently we suspected injectors, and we spent about 7,000 to repair the injector. The vehicle came within 2 days, the engine broke down. And the engine is 45,000. And so there's no way we can get that 45,000 within a few months, or had to go and repair it. So if it's a minor problem like bulbs and other things, we are trying our best to repair them. And in the region, we don't have tire problem. That because of tires, the car is not functioning. The problems that we are currently having, they are all major problems. So
okay, Madam Alice, we appreciate your frustration. We all have our deep-seated frustrations where we work. So we can only say we are praying for you and then for us. And then the stakeholders, my boss and then when they meet at the highest level, I'm sure it's one of the issues they can discuss. So, you're okay, right? Right, so we can humbly discharge our panelists from the high table. Thank you so much. I think we have discussed, so there is no point, but especially the medical superintendents and the medical directors own the data. How many of us still have our DIMS password? The doctors, do we still have our DIMS password? The medical suits. Please look at what is being keyed into the DIMS on your account. Look at it. Your monthly data validation, take interest in the data that we are sending out. So that was good. The facilities, you cannot work in silos, and it was made especially here. They cannot work in silos. We need to join what you have, what I have. Then we find a way of working at different levels. And of course, measurement. If it cannot be measured, then it cannot be done. So I think you do agree with me that the topic network of practice at the engine of UHC, coordination, referrals, and accountability at this level has been well discussed, and I have taken a lot from it. The ambulance, the data issues, accountability, the coordination, and the goal. On that note, I want to thank you. I want to thank you for your support during our panel discussion. Thank you very much once again. At this point, we want to have a 15 minutes break for snacks. 15 minutes. It's 11:26, 11:25. 45, so 15 minutes, 30, 40, and then by 40, 11, 40, we are back here. Thank you so much.
Area more training. Area more going to come up But we have to get it understood. So if you prefer do you have it on the phone? Yes. But you can't go. So let's share on my WhatsApp so that I can follow you. You can log in. Use what?
My phone is there. No, this one I don't want to buy.
You can log in. Or you just do it.
I can, okay, let me put it.
Okay, do it.
And when I was playing, I couldn't get the name. That is why
You couldn't use it.
I don't know the name. This one.
Yes.
This one.
Wait for the other one. This person.
Oh, why not? You can put it down. But the range, you can leave the two and put it. for download. You have
Yes, yesterday. I think when the internet went down.
so you were the one.
Yes. Small.
That's like
No, I was just looking for a number to dial. But like, okay, please I've sent it.
okay, that's fine. So I will say, let me say.
I wanted you to look at last the careless effect. And the front side. No, not like as I'm talking about me, because I did this like as with the machine that I used, it was giving me the best. And but when I got it here, I had things blah.
Probably they should be every 2 months. Ask them to obey receipt. Even with my phone. This is it, right? Or it's not the phone? Chairman. W. I mean, they forward.
Emma, mais on s'est encore fait celle-là à moi. Ok.
Maybe my members are rich.
Which? The slice. The 20 slice, you have it. The principal. He said it with you.
I've received some slides, but I don't know.
Misaka. From the Ankara principal. Yes, please. This one. So that follow it. This one. That's the next one. So you can open this one and that one. Directly HR. But this one will be first.
You have opened it.
And you open it here. Okay, so let's open this one. Go ahead. Yes,
it's the same guy.
Yes, so I think apparently he but we found it now. You have to snap it, you are the one who will present it. Okay. After we go ahead, we'll begin to say what you are. A special presentation. Special. After break, go ahead and present. Yanko, as young couple woman now, I'm brown, not Thomas.
Hello. What is it you want to present? So you have said the idea. Yes. Right. Yeah. So is it a specific
One shift. I can't change one shift. Post.
Oh, in fact,
Presentation.
have worked on it.
If on it, you know, okay, it's super.
We are moving on every day. It's always a
the moon is swimming gardens. No way. Oh, no, about
so you don't.
That's what guy in the but they would there are some views that or they but they would so any more than one 22 or 20 main monitor.
We actually took it serious.
But the wire opposed. On it. Interaction screen. I mean, why? I'm not to run a presentation on mine. My share screen. Man, but say info on never no problem. Let's put you friend.
You know that this was over. I know there are so many things.
Welcome back from the snack break. And we want to continue. Before that, we want to acknowledge the presence of Sir Eliasin. He's the Dean of University of Cape Coast School of Medical Sciences. Past Dean. I have to update my records. Immediate past Dean of GCC School of Medical Sciences. Prof, you're welcome. For the next session will be chaired by our own medical director, University of Cape Coast Hospital, and also a member of the regional health management team, the person of Dr. James Pra. With a round of applause, join me in welcoming Dr. Pra. Yes. I just returned from last night, so the energy level is high.
Just one mic. Video. We move up and down.
I'm sure we have been energized. Yes. We thank our Mami, the regional director, who thinks about the children and knows that children need food to move on. And we are hoping that the lunch will even be better, isn't it? Yes. So whilst we wait for the lunch, we must also make sure Mami is happy, because she spent a lot of effort to put this program together. And so I'm very happy and privileged that I've been invited to chair this session. And I know that it's going to go on well by God's grace. Because of some circumstances, director has approved that we do a little tweak to the program. And so, with permission, I hope that with your indulgence as well, we want to begin with a presentation by the collective group. Yes. And the presentation is on the media performance updates. And we have on the program, I don't know if it will be the same person to present, but we have Madam Dr. Hannah Yosin, the regional chair of Koheti. Please, let's welcome the program.
You have to use it either than that it's going to distract the Zoom down. So you can still keep the phone whilst we are waiting for you.
Good afternoon, Dr. Good afternoon, all I'm here, my name is William Abidu, and I'm here on behalf of Koheti Central Region to present the first half year performance review. So we have a background. As presentation outline, you have the background, you have three highlights from January to June. We have admissions and student recruitment. I'll also be talking about governance and institutional strengthening. I'll also talk about academic and regulatory matters. And then upcoming regional activities, challenges, way forward and conclusion. For the background, the Central Region has 6 public health training institutions responsible for training professional nurses, midwives, liver quality, and humane healthcare. So this is the geographical spread of the health training institutions in the Central Region. So for the regional snapshot, we have 6 institutions which has 8,472 students with 547 staff, that is teaching and non-teaching. And then we run multiple accredited programs that are Ministry of Health, NMC, and GTEC. So we have, this is the leadership of the 6 health training institutions. So we have Dr. Hannah Yosin, who heads the College of Community Health Nursing in Winnipeg. Then we have Mrs. Essential Morty, Nursing and Midwifery Training, so Mrs. Nursing and Midwifery Training College, Cape Coast, Mrs. Christiana Malva, Nursing and Midwifery Training College in Pornofin, Mrs. Joyce Autry, Nursing and Midwifery Training College at Cinema, and then my very self, William Abidu, attached to Nursing and Midwifery College. So these are the key highlights. So we're here January to do the annual review. So February, advisory boards were constituted. And then in May, June, we started the online application process by the Ministry of Health. So the forms were sold. And then in July, the Ministry of Health organized orientation for board members. And then selection interviews also began from the 27th of July till today. It's ongoing. So with admission and student recruitment, as I've already highlighted, it was online. And then selection interviews also started on the 27th of July. There was also admission quota rationalization. So the ministry reviewed the admission quotas for all health training institutions. The reasons were that there were a backlog of graduates who had successfully completed training and they were home. And also there were delays in also financial clearance and posting. And then there was the need also to align admissions and training with governmental policies and the national health care needs. So the implication is that this year there will be reduced student intake for the 2026-2027 academic year, and also there will also be pressure on admission protocol. So with the advisory board, the governance and institution strengthening orientation program was organized for them as I indicated in July. So the trust was to educate them on governance responsibility, strategic planning, institutional accountability, financial oversight, and then policy implementation. Our students are all on clinicals because we all vacated at the same time. So most of our students are on clinicals. And we are grateful that we are using the teaching hospitals, the regional hospitals, the district hospitals, psychiatry hospitals, and the community of facilities to do this program. So for Haiti, we have an annual general meeting which is upcoming in November. And we will bring the date and then the venue. So many challenges. We have reduced admission quotas, inadequate staffing, infrastructure deficits, hostel accommodations which are not enough. We have limited and overage vehicles. We have funding constraints. ICT infrastructure for our online examinations are not enough. We also have challenges with staff accommodation, and then we are also back land encroachment. So the way forward, we're going to continue strengthening institutional governance through the effective advisory boards which have been inaugurated, and then also ensure transparent and merit-based admission processes. And then also strengthen collaboration with the Ministry of Health and relevant stakeholders to address the workforce planning, and as well as for staff to align with the emerging nursing and administrative practices. And then also strengthen relationships with stakeholders and our partners, and then increase internally generated funding. So with the partnership and stakeholder engagement, we are very grateful for the collaboration and strong partnerships with Ministry of Health, affiliated universities, Central Regional Health Directorate, the National Military Council, GTEC, Cape Coast Teaching Hospital, traditional rulers, and then MMG aids. So these partnerships will continue to strengthen quality nursing education. So in conclusion, the first half of 2026 has been marked by significant progress in strengthening our governance system and in preparing for student admission, and then also enhancing our collaboration among the health training institutions in the central region. Although we have a reduction in the admission quotas, it's going to present a challenge, but the institutions remain committed to maintaining high standards in nursing and midwifery education. So we believe that through stakeholder engagement, which is continuous, and then strategic planning, the central region remains well positioned to contribute to the development of a competent and then responsive health work. Thank you very much.
Yeah, we thank you so much for that very straight to the point and great. In fact, you have done very well. You have saved us some time. At the same time, you have given us a lot of information. The regional director directs that because you are on your way for a program, we should open the floor for a few questions. So please, if you don't mind, just a few minutes and you can take it. So colleagues, the floor is open for any clarification, any questions, anything that was said that you wish you could get more information. You can take about 2 questions.
Very clear presentation. Please, the reduction in quota, was it because the previous year you took a lot more than your facilities could accommodate? Because I heard in last year that more people were being exported as well. More of the trade groups are being exported. So I thought rather there was more room for more intake. So that's why the decision on the reduction, I just wanted the basis. Thank you.
So hello, I think you just said that because we have backlog of staff, and when we train more, they are going to also join them, and they are being impatient to relax for any person to come, and they are always disgracing. It's not good for the profession. They are disgracing and embarrassing us. That's notwithstanding, I think last year some also abused the quota that was given, and some also over more than they were supposed to have done. So the two are together making this thing possible. Thank you.
Thank you for that response. Please, one more if possible, otherwise we turn the collective group. Okay, so it looks like we are very satisfied with your presentation. I want to say a big thank you for the updates, and we wish you well in your admission process.
Thank you very much, Dr. Hannah Johnson and the other principals. We appreciate you and continue to work together. Safe travels.
So, with those remarks from Director, I think I have the permission to proceed with the papers. Thank you. So, at this point, we want to go by what we have on the program, and I can see that we have an expert presentation. And the presentation is going to be on human resources for UHC, staffing, motivation, and tax sharing for free PHC, chips, and networks of practice. And it's going to be done by an expert. This expert is a big man, and I will tell you more about him. But he's the president of the Director of Human Resource and Development Division, Ghana Health Services Headquarters. He is Mr. Peter Obreyeboa Esquire. Please, with a round of applause, let's welcome this boss, experts in the field.
Good day to all. I know I'm going to make a presentation, but as to whether it is an expert presentation, at the end of the day, you would have to judge, because I know I'm part of you. And also, because of time, Uncle Becca, you here? The presentation will not be exhaustive. So, if you find anything missing, pardon me. All right, so I've been asked to present on human resources for universal health coverage. And we are looking at how staffing, motivation, tax shifting and sharing feed into free primary health care, CHPS, and networks of practice. So it's a very big area that has been given to me by the director. I'll attempt to do justice to the presentation. All right. So by way of opening statement, I would say that UAC is the aspiration that all people and communities can access the full range of quality health services they need, when and where they need them, without suffering financial hardship. So that is the focus of UAC, by 2030 or whichever data has been fixed. All persons living in Ghana, if we are applying to our country, will be able to access health services at their local levels and without any difficulty in terms of financial requirements. But at the heart of every health system are its people. As you are aware, health provision in our parts of the world is labor intensive. If you travel outside the country, you notice that some functions are performed by or have been automated. But if you come here in Ghana, almost every part, every aspect of health delivery is performed by a human being. And so it's the reliance on human being so great that without having the requisite number of persons at the various levels, you cannot provide the service. So as you are very much aware, it takes the doctors, the nurses, midwives, community health workers, pharmacists, and other allied health professionals to turn policies and facilities into actual care. Thus, without their right numbers, the right skills, in the right places, doing the right jobs, UHC risk being an unfulfilled promise. So, Dr. Ali, when he was at headquarters, he used to say that the politician will come and say that, I want to do this. So this is the policy. Next year, we are going to build 50 CHPS compound. Then that will be the end of his job. You, the technical people, will now go and sit down to think how you are going to translate that policy to reality. And so, if we say UAC, if we say free primary health care, I don't know, the minister who launched it is done and gone. The work now sits on the regional data, the national data, the medical soup, and the health professional who is at the local level providing the service. I hope you understand. And so, have such a huge responsibility to the extent that if we fail in what we are supposed to do, then the whole idea about UAC was what failed. And that is why the council chair was so passionate about the role that some national directors are playing at the national level. Because the Ghana service mandates depend on the lower level. And so if you have the management level at that community not functioning as expected, then we have an issue. By the end of the day, all that we do will not have the ultimate result. So this presentation outlines how staffing, motivation, and tax shifting or sharing may help in addressing issues bordering on human resource in the pursuit of UAC. I mean, we can't have all the people we need. That one, no one can promise you that. We won't have all the nurses, we won't have all the doctors. At a point, we'll have to manage what we have. But how do we make sure that we put these available numbers together to achieve the stated objective? So this is how my presentation is going to flow. I will dissect few key HR terminologies that have been used, and after that, I'll move on to provide overview of free primary health care, CHPS, networks of practice, and UAC. And then, from the HR perspective, we look at the implication on HR. We will move a step down to analyze our current human resources as we pursue UAC. Then we will descend to using staffing, motivation, task shifting, sharing to address HR gaps. And I'll conclude. And beyond the conclusion, I'll travel back to demonstration. All right. So key HR terms have been used. Staffing, motivation, task sharing, or task shifting. So I'll start with staffing. Whenever we mention staffing, what comes to mind is having people at the various levels. You travel, you go down there, Dr. Abdul will come, oh, our staff, they are not there. See, that's only one community health nurse. Then the medical suits, oh, here, what is Praso medical suit? I haven't seen Dr. Lindsay. The last time we were there, so the human resource, what do you do about it? So when you talk about staffing, what comes to mind is what? Having the human being at post. But it is a key component of human resource management. And it involves finding, choosing, training, and keeping the right people to fill jobs in organization. And so it's not just about looking at the end state where you have the human being there, but it is a process that you would have to undertake from the level of finding who, choosing who, and giving the requisite training, so that at the end of the day, you have the full complement of the required skill at delivering the job. So it involves planning. Planning is a key aspect of every manager's work. And so we talk about HR planning. It is not the work of the human resource manager to plan for you. As a manager, you must plan. And so if you are working in a district where the DCE has started constructing chief compound, now they say 2 per district, is that not it? That is it. The district director should start thinking about it. If the facilities will become available now, who and who are going to move in? How do I get the people? So that is how the planning starts. So if you wait, when the facilities have been completed, commissioned and handed over, to now write to the region that we need staff to operationalize the facility, then you have failed in your duty as a manager. And so when we talk about staffing, the first thing that we should take is the planning. Then the recruitment bit, you may not have the full control, but what contribution do you make into it? Okay, there are certain cadres that will not make sense to post from other places to your location. This is where, as a manager, you can make input into the planning. Orientation and placement. Now, we post people to you, and without any proper orientation, they are due to provide service. We are having a lot of challenges because of the ineffective system of orientation that we are having now. We see it as a cost. And so many of us don't pay attention. Those who do, yes, maybe one day will bring everybody together. So you have a room nurses, a professional nurses, a pharmacist, all of them sitting in one room. That is not an orientation. That is not an orientation. And so you want your staff to receive the basic and relevant information that will help him or her to settle effectively to deliver. Then you need to invest in that. And so as you move along, then probably during your budgeting stage, all these actions should be taken care of. Training and development to improve job. Training on the job to fix skills. Development is looking ahead, looking at leadership role, future. And so the two are also essential components of the managers. And so if you don't take interest in the training and development of your staff, at the end of the day, everybody goes to school, runs away, and you are left with nobody to work with. And so it is also critical that in considering staffing, we look at it. Then the last bit will be the performance management. We have a lot of people working, but the resources is zero. Travel to some health centers that we have about 3 midwives sitting down there, but the delivery, the outreach, everything, if you put together, you maybe need just one. But nobody cares they are there. And in some cases, they even run shift. So one goes away 1 week, he comes, another person travels. So that is it. And the manager is not bothered. And so when we are talking about staffing, all these things will come together, and the end state is you, the required number of employees or staff in their right complement working to achieve the stated objective. So I have talked about planning, availability, orientation, ensuring appropriate means, training and development, and then where you manage the output. The second terminology used is motivation. And motivation is a common terminology which means different things to different people. I hear you go around to find out what motivation means to you, you would hear the response. Is that not it? And as managers, typically, when you go and say, oh, motivate to grow for us, oh, in this car, that's the first thing, you don't have money. In this car. I think 2 years ago, Dr. Beta maybe, say there was a follow-on network of practice. Managers were brought, some staff. We had some community health nurses from Bosumefra who came to testify how the district director of health service contributed to his development and for which reason he has remained in the district till now. That is motivation. People look at you, see you as the figurehead, and they are inspired. That could be a form of motivation. But if they don't even see you, you don't mind them. So sometimes it's not about money, it's not about what somebody is, but it's about how people are treated. So in this context, we are simply looking at the force that drives, guides, and maintains that behavior toward the achievement of specific goals. It explores the whys behind what staff do. Why would the staff wake up early and go on outreach when you are not there? You are not there, you don't stay in a chief compound with the community health nurse, community health officer. But every morning, wakes up and moves into the community. You should be interested in what moves that person to go without being told. There's something that is pushing that staff to do that. But we take these things for granted. So this force can be from within the person. That is maybe the satisfaction of personal joy or the interest in the performance of the duty. It could also be from work environment, including physical environment, equipment, and safety. And usually, we pay attention to the work environment. And that's what you go into the test with. They will tell the hygiene factors. Allowances, salary, other benefits. That is what motivation is. But there are other things that we can do. The inner feelings, you cannot have control, but you can enable staff to be happy. You can. So it is acknowledged that managers have control over inner forces that drive performance. However, they can influence them by creating an enabling environment where staff can experience them. And so you create the environment. You go to a place, you don't even see the manager, everybody is laughing. Where's Dr. I haven't seen him. I was at Tufras, is it Tufras? And I was happy with the doctors and others, how they relate to each other, they pass the doctor. But you go to some places where doctor is coming, everybody sits. No, I said that Dr. You get it. Sometimes the environment alone inspires people to work. And so please, when you move here, let us know that it's not everything that requires money. So this is done when managers foster 3 psychological needs, namely autonomy, competence, and relatedness. Environmental factors, which are usually referred to as hygiene factors, however, fall within the control of managers. All managers, irrespective of location or resources available, are able to do something in furtherance of environmental motivators. I mean, some places, one of the facilities in Greater Accra, every month, they say the medicals will give them MTN, of 10 cities. But OPD, 5-star assistant, 10, all them. That alone, 10 cities, MTN, what is 10 cities? But someone is so satisfied that, doctor, thank you, but some places you go there, even the work that the staff has done, the person is given blank document to sign. Blank document, you write your name, no figure, you sign. Then someone is given to you. At the end of the day, they will sit down and calculate how much so that they will balance and update the spreadsheet. All these things, you think the staff don't know, they know. They discuss. They know and they discuss. So if you are going there, they will look like a bush, that is it. So the environmental factors, the things that we have control over, we should also have the interest of staff at heart. The fact is that only managers know their staff are able to identify what motivates them. If you don't know your staff, you can't know what will motivate that person. You can't. Some are difficult, yes. Like me, I'm difficult. You can be as close as to maybe what motivates you know. Was in history for it. Some are like that. But there are some people, when you are close to them, you are able to detect that this person, if you do this, you will have the best of it. So please, let's take note of this. The third term, which is tax shifting or sharing, could be explained as the rational redistribution of tax among health workers, health workforce occupations. This involves delegating or transferring responsibilities from trained and qualified health workers to those with shorter training durations, thereby maximizing the available workforce. In tax shifting, specific tasks are created, while tax sharing involves collaborative delivery of services by categories of staff. And so you go to a maternity, you have a midwife, a policy health nurse working together. And so when the pregnant woman walks in, the community health nurse will do some bits of the midwifery work, and the technical midwifery duties are taken over. That is tax sharing. They are collaborating. When you go to some places that you see that the tasks have shifted completely because somebody has taken the job of another person. Let's say a health center, you need a dispensing technician you don't have, and you have trained and enrolled nurse who is at the counter giving medicine. At that point, it's not, the person is not sharing, but the person has taken over that duty for that moment and performing as if it was the trained person who is doing that. These are key HR interventions that are used to address human resource gaps. So this is very common, with about 22 countries in Africa implemented, including Benin, Botswana, Ethiopia, Kenya, and these are all strategies aimed at addressing their peculiar HR needs. So why do we implement shifting or sharing? One, it is implemented to address deficits in health workers to deliver health services within specific areas. The health worker shortages could be at the level of care and geographical location, especially in the underserved areas. I've mentioned it. And so maybe because of where you find yourself, because of the issues with availability, you train certain cadres to perform certain duties. So another reason for implementing tax shifting or sharing is the need to optimize utilization of existing health workers, especially in areas where there is oversupply. There are certain areas, you and I know that now, wherever you go, wherever you find yourself, there are a lot of enrolled nurses sitting down. Some are running to school, some are not doing anything meaningful. And so tax sharing will make use of this available cadre that we think they have been overproduced or oversupplied. And the last one is the need to increase access to health services, including expansion of services to other areas of care where the primary personnel responsible for certain people are not available. So where you want to expand care, now maybe Abradupal, you want to provide geriatric services. You don't have anybody trained. In a moment, give some orientation to some people to provide some level of care. You get it? And so the first one is that one, geographical location you can apply. Two, when there's oversupply of professionals, you can also utilize tax shifting or tax sharing. And then when you want to expand service and then you don't have availability, now we are going to NCDs, right? NCDs. A lot now, Ministry of Health has started training. But between now and when the first cohort will come out, what happens? We can't wait. And so is it possible that some professional nurses could be giving some orientation, giving something, whilst we wait for the professionals who may be coming out? So that is the instance that we are talking about here. So this suggests that tax sharing or shifting is not supposed to be permanent intervention. And we'll see the moment the wide scale is available. Now I'm told that if you go to countries like Nigeria, they have stopped training business assistants. They stopped. At the point they were training to fill the gaps. But when they felt that we are getting to a certain level, we have made some arrangements for them to develop so that they stop training. In Ghana, I know that there will be a time that now that they have even started the graduate entry system where physician assistant can continue to do medicine, there will be a time that that number will go down, and then with time we may even stop training because we would have, gotten a lot of medical officers to take over all these places. And so tax shifting or tax sharing is not supposed to be a permanent intervention. You do it for a moment. When you think that your human resource levels are okay, then you revert the system. Now let us look at overview of free primary health care. These are concepts that are known to you as health managers. Free primary health care, I don't have to spend time because you'll be told, I think there will be some orientation and all that. Or I hope you know what free primary health care is about. Is that okay? Okay. So the expectation is that free primary health care will enhance access to preventive and probative health services. In the end, facilitate the attainment of UAC. And so now government is saying that I'm going to make access to preventive, promotive services at the community level free. You don't need any child life. All that you need is any form of identification. When you go, the services will be provided. Now, NHIS will not pay for preventive and promotive services. And so outreach becomes difficult as managers. Community health nurses cannot go out to provide service frequently because you don't have logistics. Government is going to provide the logistics for you. Go out there, provide that care. In this sense, that is what free primary health care is about. And all that is expected is that at the end of the day, everybody can access these services at the local level, the community level, without any difficulty. CHPS has been with us over the last 2 days, and you are the implementer, so you know very well about CHPS. And then the fact that CHPS are supposed to have either compounds or zones. So where there's a compound, you have the presence of health professionals, the community health officer, and then where there are no compounds, you have a community health officer or community health assigned to provide services, catchment population from house to house. So in its CHPS is to provide maternal child health, preventive and promotive services. They are also supposed to have prompt notification of doing diseases, death, and then NTDs. Okay? Or when it comes to clinical, what all that they are supposed to do is to manage minor ailments, including fever control, first aid for cuts, burns, and domestic accidents. Any other issue are supposed to be referred. But you and I know that the situation we find in our districts, our communities are quite different. Where CHPS compounds have become static clinics. The last time we went on monitoring, we saw one of the CHPS compounds, struggling to even keep the folders of patients, looking for a place to keep folders. I got surprised because now it's like a small health center. CHPS is now like a small health center where people sit down to wait for patients to come and then they diagnose and treat and file records. I think some of these others, you even know the level of generation of CHPS. But if you look at the nature of CHPS, they are not even supposed to generate. They are supposed to provide preventive promoting services, which are currently not paid for. And so with the coming in force of free public health care, now funds are going to be made available for those services to provide. But now if you go, some have ledger books at the districts. They count number of patients seen. I don't know, I think we have changed everything, but that is not supposed to be the focus of this. Networks of practice has also been with us, and just as the panel discussion, the panel discussed, it is mainly about coordination of resources, both material, human, for effective delivery of services at the community and district level. And so it's always also been with us. So in effect, if you look at CHPS, free public health care, networks of practice and UHC, CHPS addresses geographical access by bringing healthcare to the doorstep of the people. That is CHPS. Free public healthcare intends to remove financial barrier to healthcare at the community level. So, one, CHPS is helping us to address geographical access. Free public healthcare is also dealing with financial access. NOP engenders coordination amongst the various points of care and ensures effective use of available resources. So when you have the geographical access, you have the financial access, NOP is helping you to coordinate your efforts so that you don't work in silos, just as it was discussed. If you look at all these things, then the three CHPS, free public healthcare and NOP are all strategies for attaining UHC. UHC represents a destination or a finalized stage where equity, financial protection, and full healthcare access are achieved for everyone. So, in school, is it subset and there's a mathematics, there's not this. One more super power. You have what?
Venn diagram.
You have
Venn diagram.
Venn diagram. Where you have what? Subsets. Universal set and subsets. So I thought I was just testing you. So it means that UHC will be the universal. Is that what it is? Which CHPS, NOP, free public healthcare, subset, all working into the universal set. And so we should not be confused. We should not be looking at this as different things. They are all working towards one desired goal state, which is the universal healthcare. Now, as HR, the question is, what human resource do we need for UHC? The World Health Organization refers to HRH as the heart of health systems. This is because health workers are the essential drivers of care, central to UHC, and cannot be replaced by equipment or building. I've told you, UHC, free public health care, preventive promotive services, you need to move into the community. I'm yet to see a robot that would move from one house to the other, giving immunization. I'm yet to see one. Maybe those of you from Tifras, you have seen one. And those of us in Accra, you haven't seen one. So, under UHC, attention is paid to three critical dimensions. Who is covered, what services are covered, and how much is covered financially. And all this, you find the human being there. So the HRH cuts across all the three dimensions. This is because coverage exists on paper if clinics are empty. So if you commission CHPS compound now, and you don't have community health officers or community health workers working in there, you can't say that you have a functioning chip. Is that what it is? So you go and find a building, but no services are provided. Quality drops if right caliber of staff are not at post. So you will have hundreds of people working in a hospital. If the skill is not there, at the end of the day, medical legal suits will be lawyer, order, otherwise, medical legal cases will going up because quality issues will come up, and you need human beings to fix that. And the last one is that financial protection feels if patients pay more for private care due to public sector gaps. So, or even if you go to public sector, you are attended to, and you find Mr. DDF's staff sitting down there under carbonizing or overpricing, then definitely all the health interventions should have failed. And so you can say that throughout the chain, you find a human being affecting the outcome. And that is why the WHO says that HR is for human resource for health is the heart of every health system. Because all that you do, whether geographical access, whether quality issues, whether financial access, it will be paid by human factor. And whatever the human being does will affect the outcome. So HR implications. One, UHC requires that all people receive quality health services when and where they need without suffering financial hardship. A huge part of UHC is preventive and promotive. In fact, the health economists and the planners say that about 80% of UHC is preventive and promotive. And don't be surprised when you see the minister so excited just about free primary health care. Because if you are able to do that, you would have covered 80% of UHC, and then your attainment will be in line. It is argued that the cheapest, fastest, and most effective way to achieve universal health coverage is to stop people from getting sick in the first place. So you stop people from getting sick. How do you stop people from getting sick? Give education, provide immunization, and then provide preventive health services. We did the exercise. Sometimes what you trouble I find lack of exercise, which one wiring. To why that, then the person will end up in the hospital. You spend more. So the focus of UHC is that catch them young. Yes, sir. So you don't wait for them to get sick. Just make sure that you provide those services. So you do not wait and just treat them after. The implication for us as managers is that this calls for a change in HR composition. Now, we need more community health nurses, community health workers, midwives, health promotion officers, nutritionists, and the other service providers that are involved in the preventive and promotive health. Again, deployment must target the communities and sub-districts. So when we were distributing staff, Cape Coast Metro needs no, but the person should go to the Rodum Camp. Because that is where you find the typical community members. Cape Coast, I said, Abrofa no too much. So they know what to do. But at some level, you need to tell them what they should do. So you need them there. And we need to change focus from number of patients seen to prevention and promotive activities implemented. In fact, the next time I come and I see, if we start the free primary health care, and I see that we are complaining about dropping OPD attendant, I'll be very sad. Because if our preventive interventions are working, then we don't expect people to get sick and go to the hospital. Is that not it? So very soon, medicals will put near demand here. Because we are I have to go from Combedo. So that is the mindset that UHC, free primary health care, and all that. That's the mindset that we need to have. Now, I will not be counting the number of patients that we saw, but the intervention, the preventive and the promotive activities that we implemented. Let us look at the current situation with HR. As at mid-year this year, the Ghana Health Service had 120,695 employees, mechanized. Central region, my dear sister, regional director complains, but you happen to be the fourth with the highest distribution, commanding about 7.8% of the entire workforce. So you have 9,383. We're even better than Western. And then you are better than my own region and a half. So, as at half year, the Central region had the fourth highest in terms of numbers after Greater Accra, Ashanti, and Eastern. This means that the region is not that bad in terms of HR, even though we have to, the current numbers are not enough. If you look at the distribution within the region, that's where we have issues. You have Cape Coast commanding 10%. Ewutu Senior East 889. Efutu 857. Infantiman 641. Where you have Goma Central 162. And so you see, Cape Coast, Ewutu Senior East, and Efutu host 2,700 staff. Close to 3 in every 10 staff that you pick. If you pick 10 staff, 3 of them are found in these districts, leaving the other 19 districts with the rest. The 5 smallest districts, Bumwa Central, Upper Denshira West, of Tufuhiman, Lower Denshira, and the Kumfi together have 889, which is even lower than that of Cape Coast Metro alone. So that is how your situation is. So if you are talking about moving into free primary health care, where the concentration will be on the community level, then we need to look at how we locate our staff. Would that call for redistribution? I don't know. Would that call for realignment? I don't know. There is a decision that all of us would have to take. I picked on cases that are crucial for free primary health care. Community health nurses. You have a total of 1,333 as a region. But again, you see, Ewutu Senior East has 106. Infantiman has 108. For PA, for midwives, you had a total of 1,526. And again, you see where they are. And I don't know, Goma Central, whether they have health facilities at all. Do they have health facilities? Okay, so you see, the whole district of 49 community health nurses, some of which are in school. So at the end of the day, if you are saying that district performance review and I'm being matched against Cape Coast, then assessment is not fair. Is that not it? It's your way, I mean, but on a serious note, from the table, you see that you have a high number of enrolled nurses which don't count when it comes to free primary health care. That is about 1,835. Midwives, you have 1,526. Community health nurses, you have 1,033. PAs, the whole region, you have 154. But Agora West has 15 PAs. Ekumfi, Hifo, Lower Denshira, and Upper Denshira West, each have 3. So we have to look at the distribution. Midwifery numbers deserve attention in few districts. Bumwa Central has 23 midwives, and the Kofi has 25, against 183 in the Utusenya East, and 140 in the Futu. Okay, it is worthy of note that concentration of staff in Utusenya East in the Futu may partly be due to the siting of fake health facilities. But even that, we need to look at equity. If these are the few numbers we are sharing, then the concentration should not be like that. So regional data is something that you need to look at going forward. So in summary, you will need a total of 2,744 community health nurses. You have 1,333 representing 48.6 staff availability, which means that you have less than 50% of your needs, which is bad. For midwives, it's better because at least you have 86.1%. You have 1,526 as against 1,772 required. But the distribution here is a challenge. Most of them are at the hospitals and health centers. At the CHPS level, nil. Few ones are there. I'll talk about road nurses because they are there 98%. But for free primary health care, if we don't do something about them, they won't help us. So let us look at specific data. For midwives, the national stock of midwives increased from 18,730 in 2024 to 19,959 in 2025, projecting a midwife to wafer ratio of 1:406. And this is from our facts and figures 2025. However, distribution in almost all the region has been a challenge. Out of the current 1,526 midwives in the central region, only 267, representing 17.5%, are found at the CHPS level, against a total need of 418. So how do we provide the maternal and child health service when the midwives are not there? This means that the region currently satisfies approximately 4% of midwives needed to provide maternal health services at the CHPS level, and you need to look at it going forward. And I have added that the 267 even include review on approved study leave, and so are not immediately available for service delivery. Therefore, in districts with high numbers of midwives in school, the situation could be worse. Implementation of free primary health care will require adjustments in the current situation. If CHPS facilities will be able to cope with the expected upset in utilization of essential health. Now they said that it's free to be able to. That is the expectation. Free primary health care, it's free. Because you don't need any time. It's so how are we going to cope with the expected set in maybe uptake? We need to prepare for that. For community health nurse, I say that if you take Ghana Health Service, our mandate, we need community health nurse and the midwife to do about 70% of the work. Because the community health nurse does everything. That's everything at the community level. Part of midwifery service is there. With 214 of them available, found in just 2 out of the 22 districts, namely in Fatima. To worsen the situation, community health nurses who pursue further studies and later public health nurses or midwives are in most cases posted out of CHPS zone. You can get furniture be a community health nurse for CHPS, you say a public health nurse. If I'm willing to work, having stayed for that number of years, I go back. But now it's like, it's a condition. Once you change uniform, you change location. Because CHPS company cannot wear white. Is that not it? But it is wrong. There's nothing against the policy to have a public health nurse at the CHPS compound level. In fact, we need them there. And so, district directors who are doing that, please, when they become midwives, don't put them in health centers and district hospitals. they are also needed at those levels. So noticing the gap, the recent recruitment at the Ministry of Health targeted 2,080 community health nurses out of the 4,626. That's about 45% allocated for all categories of nurses and midwives. And subsequent exercises, there will be another recruitment exercise getting to the end of the year. You will see a lot of community health nurses being boosted because that's going to be the focus. We are changing the narrative. We want more preventive than the curative. The PAs there, we know they are not there. We need them. The number is very low, even when you take the national number. And the region is not different. Recently, those who were recruited under NOP, government absorbed all of them. We are also looking up to a situation where in the subsequent exercise we'll have the opportunity to add on. As for road nurses, by policy, they are not supposed to be at church level. That is the fact. They are not supposed to be, because they are trained mainly for curative or basic nursing. They lack the required skills for preventive and promotive activities. However, there are high numbers of enrolled nurses at church level. We did the analysis and then they are overwhelmed. It's like they are running, they are champions. It's not the right thing to do. So the predominance of enrolled nurses suggests gaps in required skills for delivering full PH services and are gradually turning CHPS compounds into static clinics. We need to change that narrative. Enrolled nurses should be from health center, district hospital, where creative work takes place. For CHPS compound, community health nurses, midwives, that should be the arrangement. So if this cadre will matter in free primary health care at the CHPS level, then there must be a deliberate effort to train and reorient them. So this is where we may want to employ tax shifting or tax sharing if we want them to play a meaningful role in free primary health care. So how do we use staffing on motivation and then tax shifting and sharing to address CHPS, FPHC, and then NOP gaps? Staffing. There's a need to apply staffing to identify areas with excess numbers for possible redistribution. Let us look at our requirements. For upcoming CHPS compounds, staffing should be used to advocate for HR even before they are completed and handed over. Staffing should be used to balance care requirement for quality care, so that you don't pack one CHPS compound with 3 midwives, another CHPS compound with 3 community health nurses. Balance them, because that is what the policy says, so that you have all-round staff provided service. By looking at shortfalls, you can make input into staff training and capacity development programs. And then with staffing, you monitor staff performance and provide the needed remedial actions or interventions. We visited one of CHPS compounds and they were running shifts. In fact, that morning that we got there is when the one who went on the 1-week shift had arrived. Meanwhile, they are 2 there. The district has not been there for years. So they are managing their own affair. So it's now 1 week. 1 week, I'm off. The following week, I come, they also go. So that is how they are managing. Nobody is managing their performance or looking at even what they do. And we need to look at it. Motivation. UAC is not just about contacts, but effective coverage where quality care is offered. It takes a motivated staff to provide respectful and patient-centered care. Outreach services, default tracing, and then health promotion. So if you don't have somebody who is dedicated, all these activities will not, and our indicators will keep going down. It is well established that with motivation, average staff can outperform. But without it, even the best trained health worker will underperform. Therefore, looking at our current circumstances, where we do not even have the numbers to even talk about skillness, we will make the best of the available staff if we are careful to do the small things that excite them. The small things. Dr. Yip talked about the cake. Cake, after all, how much? You can buy cake. But by the director traveling to where they were to give cake alone was to be our chief compound of it of going to the and so director the about this evening. That's the next time I'm coming there. They have a topic bro. So we build that kind of relationship. Let them do the small thing that would excite them. Motivation should not be reduced to salaries and benefits alone. As managers, the way we relate with staff, how show genuine concern, offer support, and take interest in their health and well-being significantly influence their commitment and dedication. The last one, tax shifting, I've talked about it. And so, is it possible that we develop and provide training to enroll nurses to provide health education, family planning services, and assist in defaulter tracing? Can midwives and nurses, where we are having network of practice with one PA and a hub, is it possible to train the senior nurse or midwife with experience to do some consultation so that the 24-hour can run? These are the policy issues or interventions that we will have to. Addressing HR gaps for UAC may require us to look within and fashion out interventions that facilitate access to healthcare. What government looks for funds to recruit additional numbers. So we cannot wait for government to have all the money to employ all the people we need. As managers, we can look within and see how we can make adjustments to keep the system going. So in conclusion, I want to say that UAC is an admirable destination with CHPS, free primary health care, and network of practice as vehicles. To achieve UAC by 2030, we have the right people, with the right skills, in the right place, at the right time, with the right motivation. Because the success of UAC in Ghana depends on how well we manage our human resources for health. Staffing, motivation, and tax shifting or sharing are useful HR strategies that will help address parts of the existing HR challenges. So as we move forward, let us commit to counting health workers, but by valuing them, supporting them, and enabling them. That is how we turn the promise of UAC into reality for every Ghanaian. The final word is that UAC will not be built by policies and budgets alone. It will be built by motivated, skilled, and supported health workers. If we invest in our HR age today, we secure health for all. On this note, I thank you very much.
A big thank you to you, and I'm sure if anybody doubted me when I introduced you as an expert, now I'm sure the argument is settled. Yes, yes. Wonderful presentation. It's really an expert. Director, we'll take some questions. Okay. So, actually, the director wants us to ask our experts some questions so that we can end. Since I have the mic, while you are getting the mic ready, let me throw the first question. Then we will. So lawyer is having some point here when he finishes. Lawyer, are you ready? We are about to ask you questions. You said you wanted to run away to demonstration, but please, you take a few indulgences. So I want to ask lawyer, the tax shifting and sharing. How far can we go in this age of medical legal issue? You gave an example of training somebody to do dispensing. Yes, and the person is not dispensing assistant, is not, but you want to give some training in-house. So I want you to comment on that. How far can we go, and how are we protected by policy in case anybody wants to take anybody on that something happened that was given the medication by this person and they had this issue. You know, when you go to court, the first question that are you qualified? What's your license and all that? So I don't know. So lawyer, please, that's the first question. I want to take a batch of friend or friend. So, yes, please. Aha, Doc.
Thank you so much, Director, for the great presentation. You gave a nice take on the distribution of staff, but on the ground, I think a further analysis needs to be done. Cape Coast has almost 1,000 staff. The question is, where are they? All the districts will ask the same question, where are they? Most of these staff are on study leaves of various forms. Distance, sandwich, regular. And it is becoming very difficult to monitor this kind of staff on study leave. One, we don't control how their study leaves are approved. And the form, when a study leave is approved, we don't even have a copy of their letters. Sometimes we have to change them to print it from their form to be submitted to you as a head of the BMC. So in reality, we are having less staff on the ground working than what we have on records. As we speak now, 12 secondary schools, school infirmaries are like health centers and other things. As we're sitting there, headmasters are, we need staff. The meanwhile, statistics shows that people's staffing issues are treated, so you don't need more staff. So it is not as it is in the books. We need people to be to augment what is happening over there. The other issue has to do with the motivation aspect. We know that allowing or giving study leave to people is a form of motivation. But is it helping at all? We've witnessed on pattern. The higher the qualification, the lesser the work. That's what is happening. Cape Coast here, most nurses were white. Carrying passing careers, visiting markets, moving out to do community engagement becomes an issue. So, can we have some policy shift that irrespective of your qualification, if you are a community health nurse, you can go as high as the PhD level, but you still remain the same. Maybe the remuneration may change, but the work, the job description shouldn't change. If that one could be done, it is going to help us. So the issue is, where are the staff? Who controls their movement in terms of study leave? And should they move from their basic job description to a different one, to managerial, after obtaining a higher qualification? Thank you.
This is one at the back, yes. And then I think after that, lawyer will take that much.
Thank you very much for the opportunity, Chairman and Union Director. I think you asked my first question about it, but I want to add a little to it about it. In assigning a different role to the staff, do not appraisals. How do you assess the person? Do you appraise him based on the tax shifting job or his or her professional qualification? Thank you. Then the other one is has to do with this briefing that we're dealing with. Staff are leaving for union budgets, vacating posts. Can we have a system where we can have, because we always declare vacancies, we inform a headquarters about staff who are vacating posts. Can we have an opportunity to have regular replacement, such that when you notify headquarters that staff in KEA, ASINSAF, Kilkos, they are vacated posts, regional directors can declare the vacancies there, then we will be allowed to do replacement so that those vacant vacancies will not continue growing for us. Thank you.
Okay. So, lawyer, I don't know if you can. We wanted to take 4, but what you have taken so far are pregnant. So they are There are twins and triplets and monkeys.
Thank you very much. So tax shifting or sharing is usually based on a product of policy. And so if Ghana Health Service now decides to implement tax shifting in certain areas, definitely there will be a policy. The policy will outline the services, the limits, and all that. And so you don't just wake up one day and say that I don't have staff, so this is what I'm going to do. So it is based on policy. And then once there are, you have those administrative documents back in the practice, then you accept it. Okay. Distribution of staff, where are they? If I should project the age ranges, I can tell you Kunike goes to where each staff is. But it comes back to our monitoring. So I know how the system works. You have some districts, you are the district head. And so you expect that probably the staff will be aligned. And just as we have in the nations, staff are aligned to facilities. And so if you doubt the numbers, probably you can do validation. Take the information we have in nations, you can just walk to the region there, the regional HR, download the data. If they are saying that Kofi Mensah, Emmanuel Butri, whatever they are, they will validate and see whether they are not there. That is the only way that you can disprove the information we have. But from what we have, no staff is standing. Every staff is aligned. And then we can sit even in Accra and point at where someone is working and we can go straight. So it is there. One of the monitoring that exercises that we are not doing, our things that we are not doing, has to do with staff who are on approved leave to study. Apart from employees who have been granted study leave with pay regular, any other staff with any form of approval to study is supposed to go to work. If it's sandwich, the staff is required to show you the school calendar when they are supposed to be in session. So sandwich is that you take your leave entitlement in addition to any other day that you were required to be in school. Otherwise, you're supposed to be at work. You run a normal course. Weekend, you run a normal course unless you are going to write exam. And your head of facility will formally grant certain days to you to be absent. And so if as managers we are not doing that, then we are not following the policy. I'm aware that some people are on sandwich or they are doing, some are in Accra working. Recently we caught some people. They are there working. Meanwhile, you validate their salary every month. So please take it here that staff with approval to study, other than full study leave with pay, is supposed to work unless allowed by the head of facility, and it is stated in the approval letter. If the study leave approval letters or approval letters are not getting to you, then probably I will charge the region to make sure that those letters get to the facility of staff. It gets to them, right? Okay. You. Let's do the monitoring. Please, those in school, let us also follow up. We have had a lot of on-air salary. You are here, you are thinking that somebody is in school on 3 years study leave you pay, but the person has traveled. And you keep on validating the salary. So every academic year, the requirement is that the staff must submit his or her academic reports. If the person does not submit, discontinue validation. If you do that, they will return. We are saying that when they are studying in Ghana, on vacation, they are supposed to report for duty. If they don't come, discontinue validation, they will come. If you do that, you will see that they will sit up. But once they know that the system is loose, they will continue to take advantage of it. So the third one is motivation, the form of study leave, whether it's not being counterproductive. If you are community health nurse and you become a public health nurse, it doesn't mean you have stopped doing community health nurse work. That is not the logic. If you're a general nurse and you do ophthalmic nursing, You don't stop the general nursing duty. We have what we call block duties. But it's all again an issue of supervision. We don't make staff work, do their work. So if you take a critical care nurse, job description, you see block duties. You take my wife is a very operative nurse. If you are not going to theater, you will not come and sit and be chatting. You go and do how do you call it? General nursing, because it's part of your duty. But our nurse managers sometimes don't ensure that these people are assigned. And so you find people come back from school, change uniform, and start walking around. And then it's sad. When you go to the nursing, that's where you find all the highly skilled public health nurses. They are sitting there. Some days when our 4 sitting down quiet, they will come and sit down every morning. Meanwhile, the work is at the community. So the district director, these people could be assigned to even supervise the community health nurses in some zones. So the person wakes up in the morning, goes to the zones to work, and you have a system to monitor that staff. These are the arrangements that we are not doing, and we cannot turn around to complain. As was certainly in the school, people will have to advance their knowledge and skills. We can only make use of them if managers, we put them to use. If we lead them, they will do what interests them. That is the fact. How do we appraise staff performing task shift duties? Appraisal is based on objective. Is that not it? Appraisal is based on what? Your annual objective. Your annual objective is based on the work you do. And so I think that the question is settled. So if now let's take that maybe I'm performing dispensing job at the pharmacy shop, I would have been given some objective based on what I'm doing now, but not as a road nurse, because mind you, I don't run errands for the general nurse again. I come to work, I go to the pharmacy and sit down. So because this is what I'm doing, and there are expectations, you set objectives based on that expectation. You appraise the performance of that person. If you find gaps, you train that person to fill the gaps. So if you are using appraisal as a corrective measure, then definitely you will not penalize staff who don't perform at the end of the day. Because at the end of the day, you find the gaps, you put in the remedial action, and then that person is able to perform better. And so if somebody is performing task safety duty, you assess that person based on what he is doing and not what he was employed to. Last one is replacement was abused, and so it was cancelled. Argument for its introduction has not succeeded. We are, should I say, it's Ghanaians, we are not disciplined. So small opportunity we are abusing. Any intervention that comes, we abuse. Vehicle high purchase, people were collecting people's and clearing people's vehicle, collecting money. It was cancelled. Auditor is nodding. It's true. And so, replacement, Ghana Education Service, teachers left, go and employ teachers, understand they employ graduates nowadays, so they cancelled. And that affected us. Even in Ghana Health Service, you had orderlies replacing nurses and all that. It happened. Don't let us pretend. And so government cancelled it for a very good reason. We have engaged. We're not getting that approval because of the past experience. If it happens like that, then good. Otherwise, we continue with our predicament. We have caused it. Thank you.
Thank you, lawyer. I think there was a hand before the other says we can take one last round. So if there are still some thinking issues we want to get stopped, you have the mic.
Thank you very much. I think director was about redistribution and realignment. These bodies are part of the implementing district Upper Danger East. And so sometimes, the number of preventive activities that you do, that's the way going forward. But linkage with the public care, the healthcare, and the clinical, whether it's actually translating into prevention of the complications, is another matter for another day. But I think the training institutions were seeing that now the cadre of staff that are more for preventive and promotive. I think the training, the targets are going down. So going forward, how can we align the policy? Because most of the time the policies tend to run parallel, and that alignment to realign and redistribute in terms of performance for the staff. How are we also aligning the policy with other peer or institutional institutions with the policy that they are running with, so that we can sustain the human resource for a policy like the free primary healthcare going forward? I think that's the question I wanted to ask. Thank you.
Thank you. Any more? Okay.
Thank you, Dr. Chair. Director, thank you so much for clarifying some of the issues. But I wanted to follow up on the state leave issue. Is it possible? I recall to mind that GPS, for instance, when they have teachers going on steady leave, at the various campuses, they have a PV who takes care of those ones. So I believe their names will be off the active people on the ground actually doing the actual teaching. So is it possible that at our level, because if there are so many people who are on steady leave and they are all captured as if they are actively on the ground providing services, I think that is where we on the ground would be experiencing or we are complaining, raising certain issues about staff shortages. So if it is possible going forward, something should be done, not because they are not staff of Ghana Health Service, but just to keep an eye on service delivery, those who are actively on the ground. Because those things contribute to some of the low coverages that we are experiencing. On the human age rate is perfect. But the human being will go right now to the floor to get them to work. I mean, it is a disaster. Now, the other one too, with the sandwich and then the evening people. You see, the practicals from the school is also creating another wahala for us on the ground. Because they go and at the end of the period, the schools assign them to go out for attachment, to go out for, and getting them back into the district. This person is supposed to be on attachment, go to discipline work. So sometimes you really don't know what it is. And if we insist so much, there's a lot of comparison from the workers. It's like, other districts are not doing it. Why are you doing it here? Their comparison is too much. So maybe in going forward, that particular or those models, we need to get things out clear. We are talking about it, but we need to get things out clear. If they are choosing, if they want to go regular, I've been telling my colleagues that if we want to pick their regular, so that we will be free if you are giving. But you pick sandwich, and you are saying you be sent somewhere on that. Sometimes even me, I've attended a lot of them at the district to iron out some of these issues. So please, that particular one, let's look at it carefully, so that it doesn't become so difficult for the managers on the ground. These are the two issues I wanted to.
Thank you. Now, was it?
Oh, I just wanted to contribute. Sometimes when I'm listening to the policy statements, I find it interesting. Because, for instance, when the director was talking of tax shift, can a community health do health promotion? Can a community health just say that hypertension is bad, ABCD? Can a community health say that? Can an enrollment say that? Good. So if you want somebody to go and talk about something, and you send the enrollments, will there be a medical legal case that the enrollments was wrong? If the enrollments needs to dispense medications, will we say that it is wrong? Good. So I'm just saying that as long as most of you are talking about policy, I was just telling my sister that the way the policy concept you are running is like a church testimony. In church testimony, when one person buys a car, they will say, hey, we bought a car, let's all say amen, then everybody says amen. That's not how policy works. Policy, when one person hits you, you don't come and say the whole central region is hitting everybody left, right, and center. I hope you are getting me. So some of the complaints you are complaining are isolated legal leadership issues. They are not what central region does. Now the other thing I hear from the policy you are saying is that we need help from our seniors. I am a district director. I need help from the human resource director to teach me how to be a district director who understands human resources. Because if somebody has gone on study leave, and the study leave policy is clear that you should know when lectures are going on, you should know when it's off, and you don't know, it doesn't mean that we go and write another policy on it, because the policy is very clear that you should know, and now you know you don't know. Or is that the issue? So your lack of knowledge is not that you should go and write another policy. It is just your lack of knowledge. I hope you are getting me. So we should distinguish between the lack of knowledge of a district director on the job of a district director. Do you understand? Because the job of a district director has been listed clearly in the policies. And I always say that you are the policy, you the district director. So if you don't have a clue what you are doing, then that's another matter. Another matter is data quality. You are supposed to sign, in the names we've written it, district director is supposed to sign every data leaving the district. So here everybody say, let's do another policy, policy. The policy is look at it. And then when you finish, apply your signature or acknowledge. But most of you are signing without looking. And it's moving. You've been giving your password to somebody to be fired. You understand? So I'm just saying that let's distinguish what we don't know from policy. Otherwise, you'll be rewriting what we've already written around. That's the first one. The second one is that when you are analysis, now we have an age group, which is the demographic age group. Demographic is Gen Z. Gen Z is the new group. Okay. And most of you don't know a clue how to manage the Gen Z. You don't have a clue how the young people are managed. Some of you are using Florence Nightingale type of management. It won't work. It doesn't work. The Gen Zs, when they meet you, good morning, they usually say hi. Or, my children sometimes call me and their mother guys. We, the two of us are you guys. Are you getting? So they are slightly different from some of the old textbooks you read. So I'm just hoping that we don't need to write new policies, but we need to learn. Because now some of them come to work, and in the 5 years they'll deliver 3. In the 5 years, if they are delivering 3, it means maternity leave in and out for 5 years. And they finish their 5 years study leave or economics. Are you getting me? So when you are doing all those things, I'm sure it's a little more detailed than just writing a policy. So some of us, like directors, said, know your workers, understand your workers, counsel them. That you delivered one, you work small and deliver another one. No, I do that. I explain with school fees. No, you should sometimes you should explain with kindergarten fees. You understand? In our time, it was very cheap. In our time, you can give cocoa and granules. But these days, I think the baby, even taking the baby to the nursery is more than our university fees. For example. So you can use that to convince them and others. But it's your job to do that. So it's not about new policies, but your own job knowing your workers. Thank you.
So that's an experienced director. We thank you so much. So I think you want lawyer to address this last batch and then we call this session.
Thank you very much. 2 days ago, I was telling Prof that my son did something. I said, thank you. He said, no problem. I have one issue. Oh, Papa, I said, no problem. I said, you are welcome. I said, no problem. No problem. So that's how they are. Let me again add that our staff on study leave are part of us. So there's going to be a situation where staff who are on study leave will be put on a different list. In fact, staff, if you have a staff who has been giving study leave to school, count the person as part of your staff. We know that that person may not be available for service delivery, but the person is still your staff. And so we will not take their names out. 2, attachments, national service, internship, or whatever they call, is supposed to be done within the district. That is by policy. That one, if you don't know, I'm telling you. No staff can go and do rotation or attachment or anywhere unless probably you are Goma Central. You don't have district hospital. And maybe the person will have to run rotation. That is where the district director will allow that person to move to another facility that will be discussed and agreed. Because, mind you, the person is doing rotation but is still on full salary, not on national service allowance. I hope you understand. So please, don't let them bully you. If the person doesn't come, discontinue with the validation. You are right, nobody will take more. I'm saying that if you do 1, 2, 3, they will sit up. Then, I have answered whether we will capture the name of this of our staff. No, we will not. They are not part of it, so count them as part of it. And follow up on them. When they are on vacation and they are not reporting, call them. When they are about to finish, tell them, your certificate ends this day, so you must report this day. Let your HR, at least the district and facilities who have HR, let them follow them. Let them have the list of your people in school where they are, and their tab numbers, follow up on them. And then manage them as if they were on duty and working. Yes, policy realignment, yes, I understand. But I know that training, a lot of efforts are being made to address the gaps, especially in the preventive and promotive. Recently, MOH announced special programs to people for NTDs. We have been asked to release a lot of staff people and train for the purposes of free care and then NTDs. And so these are policy alignments that will happen over time. Sometimes the politicians who are now policy are ahead of the due administrative steps. So they come and tell you this is what we are going to do. Start before we think about advice. so that will be the disconnect. But with time, I know that we'll start changing our technologies. Like the promotive and preventive interventions that we implemented are yielding. And we can link that to maybe a reduction in OPD. Not until that happens, we'll continue to have this running as alongside the existing system. Thank you very much.
Thank you. I think it's really done justice to the topic. Thank you so much. Director, please, you want to say something?
Our father, thank you so much for all the knowledge and experiences that you have shared with us this afternoon, this morning. We thank you. Continue to support us, and we know that we can do even much more than we have done with your support going forward. And as you are also traveling back to Tema Station, we wish you all the travel blessings. Thank you so much, sir.
Thank you, Director. And I know you have already permitted that we proceed to the next stage. So we are going to have another panel discussion. We love panel discussions because they bring out the practicalities and the things on the ground. And once again, we are going to have a team of experts to do this for us. Yeah, so this discussion is going to be moderated by the District Director of Health Services from Gomwa East, Mr. Felix Adibari. Please, let's welcome Mr. Adibari. Say around. So while we are waiting for the director, we'll be inviting the panelists to join us here. So Ms. Susanna Bill, District Director of Health Services, Ascent South. Yes, let's welcome her. A round of applause. Please join us here. Mrs. Ampa Grant from the Regional Health Directorate. Yes, yes. Let's welcome her. Let's keep clapping while she's Thank you. Mr. Steven Tieto. I don't know if I got it right. Tieto. Let's welcome him to the District Director of Health Services, Marco Ina is here. Yes. Welcome, sir. Dr. Joycelyn Dakwa Municipal Director of Health Services, Aguna West, Dr. Ramban. And then Ms. Jennifer Munedu, the Regional Coordinator from the Regional Health Directorate. Yes, so our moderator has joined us, and so over to you, moderator.
Thank you very much. Let me just give you a very simple story. A woman in a very remote district in Central Region, pregnant, it's midnight, she begins with a lot of complications. The next nearest hospital is miles away. The road is very difficult. There's no transport. Time is running out. What will save this woman's life at this point in time? It's not a specialist as CCTH or polyclinic, but something much closer to her. And that is a functional CHPS compound, a trained community health officer, a robust referral system, availability of transport, and a network of facilities. Ladies and gentlemen, this is what we are come to discuss today. The lawyer has already given us clear definitions on what CHPS is and what network of practice is. So I will not bore you with their definitions. But what I want you to take note of, the vision of Central Region is that the health system in Ghana is changing. Therefore, we need to reposition CHPS network of practice so that we can achieve universal health coverage. We need a modernized, integrated system that leverages health, that leverages community ownership and governance, has engines in achieving universal health coverage. Therefore, the big job that our mother, Regional Director, has given us today, and my panelists, and to you, my wonderful audience, is that by the end of this discussion, we should, as a region, understand exactly our current of CHPS and network practice in Central Region and beyond. We should also be able to identify clearly innovations in terms of digital health, telemedicine, even artificial intelligence, and ensuring that we have network of practice and CHPS that actually works. Again, we should also be able to identify a clear governance and accountability frameworks that can sustain our CHPS and network of practice in Central Region and beyond. And lastly, and most importantly, as a group, we should also be clearly come out with recommendations, action points that would help us to be able to achieve universal health coverage using our network of practice and CHPS as engines to achieve it. So, I want that within the next 1 hour, you trust me with your time, so that with my wonderful panelists here, who will dissect and discuss these issues, so that by the end of the day, we come out with clear action points for Central Region and beyond. Thank you very much. I can't hear you clap. I don't know if I love you. Thank you very, very, very much. That was wonderful. That was wonderful. Okay, so I'm told that we have just 40 minutes, so I will not bore you so much. Director Steven, let me come to you first. My first question. In your view, looking at the challenges that we have as far as CHPS is concerned, when it comes to infrastructure, workforce, logistics, etc. With the vision that we have for the region, what do you think CHPS looks like in practice? And how can we address the current gaps in infrastructure and workforce?
Thank you, Director Chair. Good afternoon to Regional Director and Dr. Chair. Good afternoon to you, colleagues. I would not want to bore us with the issues about the CHPS policy because we all have ideas about that. What I would just want to talk about with this question is how the second version of the CHPS strategy looks like on the ground. So I am coming from a district. So I want to use some data from my district to illustrate how the CHPS looks like on the ground. I'm coming from Echimako Enyam district with a total population of 136,000. Now, if we look at our CHPS, population covered by our CHPS compounds is 50,000 plus. We have, in terms of healthcare facilities, so I'm saying this for us to look at the portion that CHPS is catering for, but we are saying that that is the backbone to which we are relying on. So 50,000 people plus are being catered for by CHPS for the Echimako Enyam Eastern District currently. In terms of health facilities, we have 32 health facilities in that district. And out of the 32, 21 of them are CHPS compounds. That's about 65% of health facilities are CHPS compounds. So I'm saying this for us to see the contribution of how CHPS look like on the ground. Now, out of these 32 health facilities, when you look further, you will notice that 9 health facilities are actually located in our context, urban communities. 9 of these facilities are located in 7 urban communities. That is to show you that when these 9 facilities are taken off, there is like access to healthcare without the CHPS compound will actually be a Hegelian task for the district. So CHPS compounds have actually stepped in to block or to bridge this particular gap to ensure that services are available in the district in Echimako Enyam East. Now, this 50,000 population that it covers, that represented 7% of the district population. So you can imagine that it is a substantial portion of the district population that CHPS is supposed to serve. But let's look at, yesterday, Dr. Chino was talking that it is an impression. So we decided to look at some few data in terms of, let's say, OPD. This data I'm talking about here is the first 6 months in 2026. Out of total OPD attendance of 85,000, CHPS compounds have provided 29% of the total OPD cases as a number. So that is the contribution of CHPS. This is what it looks like on the ground. So a fifth, without this CHPS compound, a fifth of our population will not have been having ready access to healthcare services that they need. And CHPS is out to address that. When you look at deliveries, still attendant deliveries, CHPS contribution is 19.3%. And he also said that out of the 21 CHPS compounds we have tried to position midwives in about 16 of them because of the maternal health challenges that we think that need to be addressed. So 16 of these health facilities, CHPS compounds are being led or managed by midwives, and 19% of the deliveries came from them. For family planning, CHPS contribution is 38%. I'm saying all this because we need to understand that CHPS is actually bridging the gap in terms of serving needs of the people. We have the policy which was talking about standardizing infrastructure and expanding. So if you also look within the district, we have quite a number of CHPS compounds that are at various levels of completion. And as I'm speaking now, I think we have about 10. Some of them are actually legacy projects. But with the current one that started last year, that each district was asked to expand 2 per year. I would say as of now, in my district, we have 3 of them being constructed. One is, I don't know how to quantify it because I'm not there. One is actually completed. The doors are secured, fittings are done, painting is being done. But the other 2 have actually been roofed. And they are yet doing the laying of the pipe for the wiring of the facilities. 2 of them are at that stage. And we also have another 3 that were actually initiated by our honorable MP since last year. They are all roofs, the windows and everything has been painted. So if you look at the number of facilities, the expansion that is going on, if all these 10, 2 of them are actually Ministry of Health initiated facilities. They are at level level, and we are hoping that Ministry of Health will quicken their pace to complete them for us, in addition to CODA projects. So if these 10 facilities, in terms of expansion, are actually brought into life, then you see the contribution. The time will come, if you look at the population and saying, CHPS might be contributing in the near future close to 50%, if not more, of services to the population in that particular district. So, as far as CHPS is concerned, you can see that CHPS is actually in Ejmango and Yan district. We are doing our best to make sure it serves the people the way the policy is designed to. This is the list that I just have to tell you. Thank you so much.
Thank you very much, Director. Thank you so much. Let me quickly make a follow-up question to Director Susie. Director Susie, you have done a lot when it comes to CHPS in your district. The workforce is quite an issue for all of us as managers. How are you addressing it in your district?
Okay, thank you very much. Good afternoon, Director. Talking about the workforce, we just went through staff issues, and then for now we know we can do tax shifting. But let me go back to previously, before all these things came into place, when communities were really owing their chips. It's like we've missed some things in the steps, because you be there, politicians will go to the community, they'll cry to them, yes, you want a chip zone, they'll build it, and then when the health worker comes into play is when they are commissioned. The community themselves don't understand anything about it. So when it comes for them to own it, all that they know is, yes, we went and then pleaded for chip zone, it's been constructed, now perform magic. When it comes to logistics, staffing, they don't have any idea about it. But previously, when they were being involved, when they were being engaged, even if it is one community health nurse that you send it to the place, because they know they need to own and then participate, that's where they will get a volunteer. Here we're talking about a volunteer with reading, writing abilities that can help you with some few things. The volunteer can help you with some home visits. The volunteer can help you with some default tracing. The volunteer can even help you with some sessions. So irrespective of you being alone that you have staffing issue, because the community has come to understand that this is, for us, and then it is for our people. Yes, government doesn't have the stuff to provide, but we can do something, because we have people with reading, writing abilities that can assist. And therefore the community will come together, and then this particular volunteer that they will take us, or they will appoint as the community health volunteer, when it comes to salary, other things, they will bear or they will take. And then he said something like we shouldn't go back. How I wish we should go back to those 15 steps. And they need to appoint somebody they really trust. And then again, you send it to them, or you present the person. This is somebody that we want to assist. Community, do you agree? And then when they agree, the person is taken through some basic on-the-job training. And then again, this is where your CHMC people will come in. Whilst waiting for other staffing to be sent, the community health people can also help you with few things. Organizing of staff there, but other few things, they can help you. So whilst we're waiting for, lawyer is gone, whilst we're waiting for them to push in more staff, I think when we engage communities, when the leaders understand that this is to their benefit, supporting us with some volunteers can really help. Thank you.
Thank you very much for those insights. Now let me come to you, Madam. Statistics show that we have only 15% of our church compounds which are fully functional. That's quite a gap. What are the 3 priorities, investments that you think that by 2026 we can do to reach 100% functionality of our church compounds?
Thank you.
to begin with, I think let us draw our minds back to what a functional chips is. As outlined in the implementation guideline, a functional chips is a chips zone that should have an assigned trained CHO. It should have the basic package of essential services being delivered from a service delivery point, and then it should also have the community level attendance like CHPS and community health volunteers to work with. And so this tells us that functionality starts with staffing, and the CHO is the minimum requirement for every zone to function. As a region, our major functional gap that we've seen from our data is availability of trained CHOs. And so if we are to lobby and advocate for things to make our chips functional, the first thing that I will talk about is training and deployment of CHOs. We already have CHNs in the system manning the various chips compounds. These are the pools that you can draw from, and then using the harmonized CHO trainings, you can train these people to be certified CHOs to act as such. And so the first thing that I'll talk about is advocating for training already CHNs and midwives we have in the system to be trained as community health officers, certified to work in that step. Again, I would also talk about reinvesting in CHPS infrastructure and essential equipment. Many CHPS zones cannot function because of lack of or inadequate infrastructure and the essential equipment that is needed for them to work. And so if we are lobbying for anything, if there is something that we need to do, then we should invest in CHPS infrastructure and essential equipment. What goes into the infrastructure? Even accommodation for staff. We've talked about it in our deliberations. Rehabilitation of some of the CHPS compounds is needed. Looking at where we are going forward with CHPS 2.0, the next version of CHPS, we need functional CHPS with adequate infrastructure. And so we should lobby for some of these. Another thing that is very important when it comes to infrastructure is means of transportation for community health officers. Their work is in the community, routine household visits, community outreaches. What is their means of transportation in these communities? So if they are investing in infrastructure and essential equipment, I think one thing that we should lobby for are motorbikes. It's very important. When we did our analysis when it comes to infrastructure, we saw that motorbike was leading as a region. So we need to lobby for infrastructure, equipment, and motorbikes should feature strongly so that it will help the CHOs work in the community, be able to go out for the outreaches and all that. Another thing, the third one I'll talk about in our lobbying, in our advocacy, for us to improve our CHPS functionality, is to look for some sustainable funding support for CHPS activities. Many CHPS compounds or some CHPS compounds are unable to fully function because of operational resources. So in our lobbying, in our advocacy, I think if we have some sustainable funding support for home visits, outreaches, it will go a long way to help us. Funding support for fueling of our motorbikes, maintenance of the motorbikes. The few motorbikes we have in the system that we saw are even non-functional. So you ask, is the facility having a motorbike? You ask, yes, functionality, non-functional. So where do we get some funds to be able to operate these motorbikes to function? So I think one of the other things that we can also lobby for is some sustainable funding support for some of these things. These funding supports can also help us in our community engagement activities with the CHMCs and the CHPS. In fact, most CHMCs are inactive, dormant, because of even meetings, how to meet, and sometimes they are looking out for certain small things, which is not there. But if there is these small funding support, it will go a long way to help activate the CHMC, which is one of the building pillars of a CHPS functionality. This funding support is also needed much for supervision and monitoring visits. Shift activities and operations are at the lower level, in the community level. We've talked about supervision this morning. Monitoring support visits is needed, and sometimes you don't even have these funds to go on monitoring and then supporting supervision. So I think if these three things, infrastructure, the workforce, and then funding support is put together, it will go to improve our chief functionality from the 15 we are seeing now to about 50 or even 100 coming 2027. Thank you.
Wonderful insights, wonderful. I just wanted to remind us that we also need tricycles. Right? Very, very important. So somebody will say, my income. Ambulance. Yes, thank you. All right, so, Madam Director Susie, let me come back to you. Still on chips and network of practice. How can chips and network of practice be better aligned to accelerate universal health coverage in that?
Thank you. So indeed, if Ghana wants to achieve universal health coverage, then aligning chips and then network of practice is really, right on point. Because I'll take it as chips is now the vehicle that we use, and the network of practice is the engine that we need to really connect rewiring and will be able to deliver very well. So before that, let me touch on some few things. There should be proper mapping. Every chips compound should not be left alone. It should be proper mapped to a health center or a hub. And then let me touch again on teamwork. On paper, mommy, please permit me to say this. On paper, we have the network, but practically we don't have it. Because there are some cases that will need them that we've left them behind. We currently focusing on the chip zones, the health centers, and then the district hospital. We've left out our TBS. We've left out our traditional faith-based healers within the community. We've left out our traditional healers. They are all working together for us to be able to achieve. If we really practice it, or if we really preaching access, they are within the community and they have directly access to the people. But when it comes to physical meeting and other things, we notice we left them behind. For now, it's like the midwives has been called in, the TDS has been called back into their shell because years back they were trained. They were giving kits and then they were giving certificates. For that reason, we have a lullaby, all delivery should be scaled. And I don't know how we communicated it back to them. They decided to just call back. You go down there, they're conducting deliveries. Because it's only the CHOs that is there. Deliveries are going on, but the community folks, the leaders will tell you when they call and they ask, tell them when the madam got there, baby placenta was already out. The only thing she did was called and then. Because she conducted the deliveries. Because they were like, we told them, hey, for now the policy says all deliveries should be scaled. So on paper, yes, we have them as a network, but how often do we meet with them? So that teamwork is not there. The healers are there, the faith-based organization. I always tell them, please, you come and raise that cap. Me, I'm interested in the spiritual thing. Albert, don't sleep. My Midora. So my Midora, my call don't catch it. So they also do the physical. And that collaboration was then there. So that's why they'll tell you, I have done the spiritual, continue with the physical. But this time around, the teamwork is not there. We're only focusing on health center, chip zone, and then our referral point. Again, I also touch on referrals, standardized referrals. Again, we've heard a lot about it. But what I want to say is, indeed, the referrals should be standardized. We know we have two cases here. We have the emergency and the non-emergency. Emergency, that is something that really needs urgent. And then the other ones, possibly the CHOs has checked the blood pressure consistently for some time, the person needs to read it. So that's where we'll have a common platform, that's WhatsApp, so that people will send information to the receiving end, so that by the time the person gets there, the receiving end has already prepared to receive. And then again, already touched on, we've already, discussed our feedback, which I will touch again on feedback. At least cases that are sent within 48 hours, information should be sent back to the CHO through the same WhatsApp. Oh yes, patient's condition, situations, and then after patient had been discharged, again another feedback is sent to the nurse. Just for the nurse over there to also continue monitoring the patient's other things till patient goes. But when it's something like that, the nurse within is also feel some kind of buzz. The doctor over there will tell you, go back. Indeed, when you take the medicine, they've written everything. This one should take one for 2 days, 30 minutes before food. But when the patient goes back to the community, send these information to, and then the nurse will also take the patient through. There's this kind of trust. So the first thing, the nurse will be always the first point that they will call. Again, I will touch on pooled resources. A lot has been discussed, but we keep saying, yes, we have a network, but as we sit here, cheap zones are behaving as if they're on their own. When you take the Gilbys, they request things on their own, they are being supplied to them, and then they also give the feedback. There is no, pooled resources. But this one, in charge of the hub, who pulled everything together. Then when it comes to the distribution, even this also helps you to monitor the kind of things that you request. Sometimes they request because they need the things, and they'll tell you, regional medical stores, if you don't do that, you request 500, they'll give you 200. So going forward, they'll request more. And if you're fortunate that they have near expiring drugs, who asks you to request? They'll push it to you, and then it will end up expiring at your place. But whereby the in charge of the hub or has an insight to this, things will go through, and then they will monitor and check so that you don't overstock or understock. And then again, I'll touch on with the pool resources. I'll touch on human, I'll touch on material, and I'll touch on funds. So when it comes to the human, that's where the mentorship should come into play. When you talk about the mentorship, we're always looking at the doctors or our medical students. But if you have a midwife who is really skillful, the person can also mentor the midwife at the health center who will end up monitoring or supervising the community health needs. They are not supposed to do few things, but at least ANC basics, so that when the woman complains of few things, quickly it will signal them that this is an alarming something, quickly refer. And then again, I'll touch on funds. When funds are being pulled together, it will help you to also support. There are some chips within the network that are financially handicapped. So when you put your resources together, at least, and then again, when you put other non-medical supplies together, that's where you know when somebody also needs it. So there's only like chief zones will be requesting things on their own. And then again, I would like to touch on working with quality data. At least we know we all have our teams. If we should get a James dashboard for the network, where we will sit together with our CHC reps from the various communities, so that we project whatever we've done within the network, and then they themselves will identify challenges that we have. They will send it back to the communities, come out with solutions and then interventions to help us achieve some of our challenges. Thank you very much.
Thank you. That was very elaborate. Thank you so much. One thing that ran through was the referral systems when it comes to NOPs. This question goes to Madam Kate. Now that the network of practice completely institutionalized, has changed coordination and referral at district level especially. And I know you have vast experience at the district level as well, so sure that we'll get a great insights into this. Thank you.
Thank you very much for the question. Indeed, network of practice is institutionalized for coordination and referral. I think that we should make the network of practice an integral part of the district health system. We should not just allow it to stand alone. And so when it's part of it, we have to ensure that we have clear terms of reference and accountability structures
And by that I mean, I think after every 6 months, the district directors, they all come to do their weekly appraisals. I think that network of practice should be one of the KIPs, the key performance indicators, and by the regional, because all that we are discussing, we want to come up with strategies that will be able to achieve by the close of this year. It's not by 2027. The director says by the close of this year. So we are in August. If district directors should come for their appraisal, that is one of the key things that either can look at. So that if it's part of your appraisal, that one you cannot do anything about it, and to make sure that all those things are done. And then again, I am in zone 3. Just about last week Monday or so, the Stockholm Medical Superintendent, we have a WhatsApp posted that, oh, I have this case and I don't know what to do with it. Can somebody help me with something? By that, fortunately we had officers online. We had about 2 doctors calling to say, oh, I can do this, I can. And within just seconds, the problem was resolved. So I think that these our digital platforms can really help with our referrals. And so the chief zones and the health centers with a referral point, the district hospital on the same platform, on how cases are being referred or the kind of cases they are having and how they can handle it and all that will do us a lot of good when it comes to referrals. And then somewhere again on the digital platforms, leveraging on digital platforms, just about 2 weeks ago, we wanted some data on referrals. Then I went to Mr. Salasi asking that I want this information on referral. Where can I get it from? Said, oh, we have a referral form in the gens there as referrals. So all kinds of referrals that we need to do, be it a delivery, OPD, any of the referrals that we need to do, we have that reporting format on it. Apart from the individual referrals that we have on individual forms, we also have a composite referral forms for referral. Unfortunately, those forms are one of the forms that district chief zones as well as the health centers are not filling. And so we are not, if you sit there, we say what the total number of referrals done over a period of time. We do not have that data. And for me, I think it's something we really need to pay attention to. We don't have to go to various facilities before we get to know. At the district level, at the click of a button or the computer, by the district, I should know the number of referrals going in from where and all that. I think it's something we need to really look at. And again, at the district level, because we are coordinating, we need somebody to help us out. So we already have the district network of practice coordinators in section. I think that they should be empowered to be able to do their work. Recently, we wanted some information, and some were able to give to us. Others, we took some time before they brought. So I think if we empower them, it will do us a lot of good. And just this morning, Dr. Darcy mentioned that he went to a place and he gave an information, and apparently some of the nurses had not even heard it before. They thought it was the old procedures, protocols they were using. So mentorship is key. Capacity building for our staff. We don't need to call all of them here. No, it's not necessary. We can do the training right with them there. So we can have the public health nurse visiting them. You don't always have to go to them in your office. Just pass by the health. So I'm coming to work with you. And I remember back in those days when I was a district director, sometimes I'll just pass to I'm coming to work here. So I bring the directorate to the facility. And it will really do us a lot of good. It also builds the morale and the capacity of our staff. And last but not least, again, last month, we had some funds to do some monitoring. And as part of the checklist, we said we wanted to find out whether a district have budgeted for network of practice activities in their budget. Out of the 22, just a few had budgeted for network of practice activities in their, just like research, what we do with research. But I think that network of practice have come to stay. And we all know the successes that we chop when we embraced, when it was the time for network of practice. We all saw it, that the resources are actually with the communities. And if we make the effort, we involve them, it will do us a lot of good. So please, budgeting is so important. If it's in the budget, then at least, if somebody calls for something, even if you do it, it will not call for anybody's activity because then it is budgeted for and then you try to go by it. And again, last but not least, engagement with our stakeholders. The district assemblies should be lobbied so that they can have some funds
for because there are times where maybe the clients come, they don't have money to do the referral, to pay for the transport. Then it becomes a challenge of sending the cases. So if the district assembly can have some dedicated funds for network of practice activities in the district, it will do us, and of course civil societies and all those people, they all have the resources that they can help us with. And most importantly, we know this network of practice, we are doing it with the private. So the chemical sellers and all that should not be left out. Monitoring and supervision should be strengthened, not only at our health centers, go down to the chemical sellers, the TBAs or the people, the private hospitals, the maternity homes, because they are all parts, and we need to have data on them. Fortunately, I think the last reports that I collected, by the grace of God, now we all have data on the various folks, not only the ones that are being managed by Ghana Health, but even the private, as well as GPRTU. Now we have their contacts and all this. I think that is a good thing to do. So having a very strong leadership and budgeting, and then having standardized referral, and also entering data into the DIMS will do us a lot of good by helping with the coordination of these activities, being the engine to drive the electrical practice.
Thank you so much. Thank you so much. Those are very great insights. Dr. Joshua, I'm going to ask you another difficult question, but I know you can answer. Now, we have two strategies, as you are aware, the method of practice and then the chips that are more or less the two foundations for achieving universal health coverage. However, when it comes to policy, I think it's a bit fragmented. It's not too clear. So, in your view, what are the policy adjustments that probably you might recommend to national to embed chips and network of practice into Ghana Health Service universal health coverage roadmap?
Thank you very much. So if you want to look at the UHC policy on its own, so that's the UHC roadmap 2030. The main goal of it is, or if you want to define UHC, that means that we want every Ghanaian to have access to quality healthcare services, irrespective of their ability to pay. So already it's addressing the geographical access that they will need, also looking at the quality that they need. As compared to the CHPS is handling that. When you look at the quality, we can get it through the networks of practice, because we are doing resource pooling. So already in the definition of UHC, we have these two terms that is running through. When you look at the objectives of UHC, it aligns with our health sector goals. The three main objectives of UHC roadmap. We're looking at the access to healthcare services, reducing avoidable maternal death or the rampant death and disabilities. We're also looking at our response to clinical emergency services. So it's already aligned with it. So what we will need possibly is to make some things clear, not an entire policy change. So for example, if we want to look at when it comes to the financing, we know that with the CHPS, we will need some form of financing. CHPS was made to be basically provide preventive services, preventive and promotive services. Most CHPS do not generate that much, but if they have to do the outreaches, they have to do home visits, they will need some form of transportation to equally be able to do that. That's those who have the motorbike. Those who don't have to take the actual transportation. So some financing will have to come in, irrespective of the free primary health care. So it has to be clearly stated in the policies that CHPS should have some form of financing, probably from GOG payout. There has to be there, it has to be there clearly defined. So that's one aspect that we can look at. If we have the free primary health care, that's fine, but that has to be stated. When it comes in terms of, I think with the medical supplies, we really get that once in a while, we get some supplies coming in, some equipment coming in, also leveraging on the NOPs, because we're expecting that the facilities would be able to address some issues. So we have some of these NOP or model health centers getting ultrasound machines. So that's already in there. So I don't think that part as well would have to do much. But when it comes to information system, we know that CHPS is doing a lot. Okay, so it's able to reach a lot of people. But when it comes to the electronic medical records, we usually place at the hospitals and some health centers. So the areas that you actually need the data from, what they are doing, what's happening on the ground, we don't have that. When it goes to the chiefs, most things are done paper. We don't have them having access to the links or the games now. So we might have to look at that aspect. They equally need that because we need that data. At times, they will give you the data of what they have collected through the links. But when it comes to records review, you go there on the ground, we know the issues with the paper-based data system. So that is one aspect that has to be clearly defined. When it comes to the service delivery, for now, we're looking at the tax shifting and then sharing. We're also looking at what is going on now when it comes to our double bedding disease. We have the chemical disease already, we have the NCDs. What can we do more, especially at the chiefs level when it comes to our service delivery and then the workforce? So probably we may have to make some adjustments in that cases. For example, when it comes to drug referral for NCDs, we can have somebody from the community taking transportation, coming for only drug referral. So can that be tweaked or changed in the policy with what chiefs is supposed to provide? I think we can equally look at that, looking at where we are all moving towards now. So we can look at that aspect as well. When it comes to leadership, certain things have to be clearly stated. There shouldn't be room for discretion. We know that, yes, we have to do supervision, we have to be monitoring, but we need those reports. It has to be probably put in a form of a system, reviewed. There has to be a system that will force people to do what they are supposed to do, not as and when they would want to do. So when it comes to leadership and governance, probably the policy should clearly state exactly how these reports, these outputs that we want is supposed to be. So for example, with the NOPs and then outcome supervision, we want some form of clinical supervision. So is it being done? Are there some particular cases that we are looking at? If it's not being done, what happens? So when we see the various outputs, that if you do supervision, you have to upload it to the things, it will be reviewed. So that can equally move someone to do what they know they are supposed to do. Unfortunately, that may be the case at times. So I think these are some areas that I can think about in ways of addressing the policy. Thank you.
Thank you so much. Thank you. Wonderful. I think we are running out of time, so I would like to bring this session to a close. I wish there was more time for us to discuss a lot more, but unfortunately, we don't have that. And so, ladies and gentlemen, I don't know whether we have time for audience. I'm not too sure. And so, it's clear that as we discussed, when it comes to repositioning our chiefs and their network apparatus, we're talking about infrastructure. Panelists have really explained what we actually need to do. We're talking about workforce. We've discussed that at length. We've discussed availability of CHUs trained. We've discussed ownership, community ownership of the program. We have discussed transportation, logistics as a general thing. We have discussed reactivation of our CHPS and CHPs. We have discussed proper mapping of our network apparatus, teamwork. We discussed clear reference and accountability, especially for managers at the district levels. We have also discussed appraisal of staff of DHS and including, network apparatus and chips as, indicators to measure our performance as managers. We have discussed digital referrals for our districts. We have also discussed supervision, most important of all. And we also discussed including network practice and chips in our district budgets. And lastly, stakeholder engagement and leadership at the district level. This, I think, summarizes all that we have discussed for the past 50 minutes. And it is clear the vision that we must have as a region. It is not about words anymore, but it's about action. Whatever that we have discussed is about action. If you actually want to achieve these clear objectives before the end of the year. And so at this point, I want to say a big thank you to our regional director for the confidence that you've had in us to come and have this wonderful discussion. And to you, my audience, for being patient with us, all this while. I want to thank you so much for this opportunity. Thank you.
Thank you very much, Director, Moderator, and our expert panel. I must say that all that you are saying is the right thing. I hope that the rapporteurs are capturing all the suggestions and the recommendations that are coming from this table and also from the audience. I'm glad Dr. Elim is here. I'm sure if I give him the microphone, he's going to say a lot of things about the networks of practice. Like you have all known, over the past 1.5 years, it's been in the law. We've not been talking about it because it looked like it's something we're abandoning. So there are gaps. There are obvious gaps. The first one I saw was the fact that I look at central region networks and they are Ghana Health Service networks. But networks of practice are not Ghana Health Service networks. They must go from official institutions into the society. So that is something that we are going to address. The clinical support is done in between. Dr. Dazi was explaining it. He called it quarterly visits or so. But it's not everybody who is doing it. There are so many things that we can do to back to what we are describing 2.0. So that is why this morning I was saying that whatever we lack in terms of knowledge, understanding, even capacity to an extent, we'll use our leadership handle to bridge that gap, because like you said, we can't always be calling people here, and it's also very difficult to always visit districts. Some will be left behind. But because we want to accelerate, we'll use all forms of opportunity that we have to catch up on what we have not done, and then I'm sure we can move forward together. There are things that I can say, but I'm sure I can say them to us in extended SMC so that we can move forward on our agenda. And Dr. Elim has agreed to also support us with the discussions on our leadership handle, both for CHPS and networks of practice and primary healthcare. He's not the only one who is ready to support. We also have people in the region who will help us. So we will be doing some of them back to back so that we can catch up quickly and move into our version 2.0. Thank you.
So I want to thank Director for the opportunity given all of us. Yes, and I'm also very much thankful, grateful to you for responding to the call. And I can see that your insights are really well thought of. I think that before taking notes, and like moderator said, we should start walking the talk. Looks like the talking is, the theory is we should get into practice. So that next time we meet here and we're going to talk about NOPs, we'll be rather talking about experiences. Yes, how we fared after all this talk. So once again, thank you very much for coming. And before Director discharges, we want to discharge you first. So please, thank you.
Thank you so much, panel, and thank you so much, our chairperson, Dr. James Bra, Medical Director of UCC Hospital. Dr. Bra, we are very grateful. And yes, he's a member of our regional health management team as well. Thank you so much. Can we have anybody to lead us in an energizer? Is Auntie Rose here? Or is coming? Okay. Our next session shall be chaired by Professor Sebastian Eliasson from the medical school, UCC. Prof, we thank you for coming. You may take your seat. Auntie Rose, please. Then you hand over to Prof. Eliasson. Please welcome Professor Eliasson with a nice clap.
Thank you very much, Director, for the opportunity. Please, can we be upstanding? We can't sit for any energizer. So please.
You can play directly and then
If we are waiting for those who are still sitting. Some are still sitting. Okay, so if you want to come and hold the mic for me.
Yes, ma'am.
So whatever I do or whatever I say, you follow the same thing. So if I have a state, I will walk like an old woman.
If I have a state, I will walk like an old woman.
I have a stick, I will walk like a fool. If I have a wings, I will march like a soldier. If I have a wings, I will march like a soldier. If I have a gun, I will shoot like a hunter. If I have a gun, I will shoot like a hunter. If I have a wings, I will fly like a butterfly. If I have a wings, I will fly like a butterfly.
Beautiful. Thank you very much. Thank you very much. Or organize a yoga class because these, icebreakers are very inspiring and very energetic as well. So at this moment, we'll be moving to the next segment, like the regional director said, and that will be moderated by Professor Sebastian Eliasson. So since he has already resumed his seat, I think he will be moderating from here. So Prof, please, your audience. Thank you.
Right. Thank you very much and good afternoon. As the icebreaker, observing fly and march like soldiers. Or if I was the commander-in-chief, I would not let them because we are not marching properly. Some were not flying very well at all. All right, so thank you for having me this afternoon. I think so far the discussions have been very exciting. I am enjoying myself. I don't know about you. Maybe some of you are sitting here sleeping. Are you enjoying yourselves also? Are you sure? Or you are waiting for lunch? Lunch shall be served soon, don't worry. Or you've had lunch. So don't sleep. Please pay attention to this exciting session. So I think the first one will be for I think the first presentation by Ms. Gifty Akusia Adigwe, Public Health Nurse, Oma West District Health Directions. I think the topic will be ability friendly towards UHC, leaving no one behind. So if she's here, let's give her a round of applause. Please let's do it better for her. She needs to be motivated.
Good afternoon, Regional Director, distinguished district directors, senior members, all protocols observed. My name is Diti Akosi Ajibe, a public health nurse and also the district disability focal person from Goma West District. I'm honored this afternoon to be among my directors to share some disability innovatives that we have from our district. We'll be looking at some challenges that they face whilst they are accessing healthcare. We'll also look at some innovations and also our best practices that we use to intervene. Then we'll also look at some success stories from them. All right. We are waiting. Okay, so whilst we are waiting for the slide, I want us to still start. Okay, so yesterday, I think the guest speaker made mention that whilst we are our best, trying to contribute our quota so that we can accelerate universal health coverage, sometimes, not intentional, we do leave some people behind. And then she mentioned the people living with disability. And that is why this afternoon we want to look at some innovations that are going on in one of the districts. Yes. So I'm not here this afternoon to teach my directors anything about disability. I know you know already. But then for us to be able to build on and to follow the conversation, we will still look at a gist or maybe a definition for disability and also the types. When you look at Ghana, looking at the disability statistics, it says that 1 out of 8 has some form of disability. Many times because when we are looking at the types, after we mention them, we don't usually add the invisible disability. And I can say that most of us here, before we even came to the meeting here, before we came for our meeting here, either we've taken some medications or some might be in our bags again whilst we are here. But because it's not seen, most times we don't even talk about them. Right? Okay. So in Goma West District, we'll be looking at some major ones that are affecting or are dominating the district. And then we'll narrow it to where are specialized. So that is how the definition is going to be like. Okay. So when I was talking about disability and I did mention of all of us or sometimes that are here and we don't even know that we have some form of disability, WHO also says that it is broad. So using an umbrella, for example, so in it is covering some restrictions, some limitations, because God in his own wisdom actually created the body that every part of it should be functional. So the moment there is a part that is not able to perform its functions as supposed to be, then it's going to restrict or it's going to stop you from performing very well, and then we can say that there is some limitations in your activities, and so we can say it's a disability, right? Good. So one scholar also says that many times it is not even about the condition, but rather the environment in the society that we find ourselves in that makes us to actually see the condition we have now to become like a disability or a barrier for us. So looking at the 715, we know that last 2 months in May, in June, after the celebration, there has been some amendments, but as we speak now, it is not out. So we are still going by the old one that says that we are supposed to provide free or let me say quality healthcare for people living with disability and without any discrimination. And then outline some parts for us to be able to go by, which are like we are obliged as healthcare institutions to be able to provide these services, and making sure that we don't have any form of barrier, be it the infrastructure
or being it communication, being a challenge that is preventing somebody from accessing quality healthcare. Then when you narrow into it, I mean, it has sections like the 31, the 35, talking about the 5 key things that we're supposed to do as an institution, where we are supposed to ensure that we have one center in a district where we can have assessment for children that would help in early detection, which I doubt we have. Yes. Then also provide free healthcare for any person living with disability. But I can say that if not because of NHIS, then there's something like free. We charge them when they come to the hospital. Then you're supposed to also provide periodic screening for this category of people, which doesn't happen. Even if it will happen, it is not something that we pay attention to like that. Okay, so this is what we have in the Assembly 1.5. I mean, adding the breakdowns to it for you with the section which is not on the slide. Okay, so now with the categories that we have, there are a lot, about 12 to 18, but then we look at only these 3. Talking about the physical disability, we know that the moment you hear the word physical, it means you can see it. So it's either you are born with it, or maybe you had a chronic condition and out of it, it's happening that you have this condition. I mean, leads to disability. Or through an accident, which all of us are prone to. So we always say that nobody is defined with disability. Anybody can become one at any time. Yeah. Then the sensory disability, when we're talking about the visual, I'm talking about all the sensory. So the eyes, the mouth, the ears. So here we have the blind, and then we also have the hearing, and then the deaf. Then we also have the intellectual disability. We're talking about the cognitive, so which are the Down syndrome. These 3 that I've mentioned, and then I've already mentioned talking about the invisible that we don't see with our chronic condition, sickle cell, HPT, that's your medications. They are invisible, we can't see. But the moment you're on drugs, they are all forms of disabilities. Okay. So just to mention the 3 because of time, then I said we'll now narrow it into Goma West. Okay. So this is the scope of Goma West. We are saying that we have 3 of these major that are dominating the district. So we have the physically challenged, the blind, and then the deaf, and then the hard of hearing. These 3 categories. So looking at the population of Goma West, of about 146,231, people living with disabilities are taking only 0.21%, and somebody will be like, oh, that is a small figure, after all. Yes. It's a small figure, but you and I in health, my directors, you know that we don't have any half person. Even a baby is a full, and so that is life. So we need to cherish life. So whether the figure is small or not, that is the population. And then when you have the breakdown per the figures that we had from the social welfare department, they gave us 303. And so when you look at it in a percentage form, you're looking at the GSP, they're just saying the physically challenged. Yeah, so they are forming 40.9%, while the NAD, that is the deaf and the hard of hearing, are forming to 28%, and then the blind are forming 31%. Okay. So I did mention that whilst we continue, I'm going to narrow it into where our specialize. So we're going to talk about the deaf community. And somebody will be wondering, why not the blind, why not the physically challenged? Yes. Yeah, right. So with the blind, because I said in the Article 1.5 that we're supposed to make the structures accessible. So if at a facility we don't have the ramp, the flat slopey ramp that would help somebody in a wheelchair to come around, then it's a place more accessible for the person to visit. What about somebody with a white cane? And you have your steps like about 6 or 7 there. That one too wouldn't make that person to be able to access the facility. But in our way around, when we have or we educate the caregivers, and so they are able to come up with them, and then we meet them nicely. We play our role when they come to us at the facility. Then it becomes a bit easier for them to access healthcare. But then when you take the deaf community, we call them a community because you all can bear with me. Since morning that we've been here, assuming this room was very quiet, and then I came in and I started signing. I'm sure you all be quiet and be watching because you are not hearing anything or you don't understand. Maybe you can remember some of the key ones that maybe back then, but then you wouldn't be able to flow continuously. So this community means that you have the mouth, but then you can't speak. You have words that you really want to express, but you can't. You have the ears. You really wish to hear. You are among people, we are here, but then whatever we are discussing here, you will not be able to benefit. And that is what makes them a bit special. So before you and I can even enter into this community, it means we have to also learn the language, learn the culture, and that is the only fit into the deaf community. And that is why we've narrowed West into the deaf community. Although we service everybody, but then we narrowed it into the deaf community. Okay, so we want to look at some of the challenges that they face. So we're taking the outpatient department, for instance. Someone comes to the facility and really want to express herself because it is based on the complaints that are able to actually derive your diagnosis from and then to give the right treatment. Here lies the case, this person is not able to communicate with you, or neither the health worker is not able to also communicate back. And so sometimes we are assuming. I can't remember somebody came to me and said, oh, I went to the hospital and I tested that she's pregnant. And the doctor and then the nurse were like, oh, your arm, so sorry, let's help you. And it's already a wrong diagnosis. Period on the arm, it's pregnant. So if you are just saying that means they are having pain in the arm, it means I'm going to give a different diagnosis and also give a wrong treatment, and you might end up making her lose a pregnancy because they're going to give medication shouldn't give to a pregnant woman in the first trimester. That just mentioned one of them. Then we move to the antenatal care, where now we are all fighting that we don't want to have an infant death, and so we are doing everything possible to curb that. So we are trying to revamp all our school, the pregnancy school, every month. And they come around, they are part of us, but we don't have any special care for them, so they are in need. So they are watching and then they play along. So when they say get up, like we're all getting up. So whilst we are flying, they are also flying. But what it means, they don't know. And it comes to a time where you're supposed to educate this woman based on because focused antenatal care. So it is focused. How focused is that if you are not able to even explain to her, to looking at her HB, telling her what you're supposed to like to eat, and so you are not able to say anything. And she too cannot say anything. So at a glance, you are like, oh, this one, these are the medications, so take. So one. Then in your own small way, and then you all start laughing. Sometimes they come with somebody to the facility, and then they are able to, on their behalf, I always that they try to tell, they are like, oh, men can say, oh, men, we are man. So they are caregivers that are coming with them, just speak because they are the grandmothers, they are the mothers, so they just assume because they were once pregnant, oh, airway, so they speak for them, and we also play along, and then they go home. What about the labor room? I know my senior managers are here, where we hear the mamichim fawenum, and they are watching you. We had a case like that, and it led to fetal distress because this death, that was the first time of pregnancy. She was also a teenager, and she's not the educated type, so she's kind of like a dull person. And so the mamichim, oh, she was doing, so she was watching. She was in pain, she was crying, but then couldn't do much. So finally, baby was born with all complications and ended up with cerebral palsy. So a deaf mother, now cerebral palsy baby that we are managing currently. Yes. So it is very serious. Then the family planning unit, where Amarose, we say that we sell our products. We try to advertise it in a way the person will understand. So we talk more, so counseling. And in this counseling, when she came, you're like, oh, why would you? Let me give you Jadel. So you've already decided for this woman, giving her Jadel. Meanwhile, she might not like it. Although she has 2 children, she would still like to go for the original that you have been taking yourself. But then now you're putting her in a different corner. And mind you, in this community, the moment one person takes Jadel, and has spotting, they go to spread the information in the community that don't go for it. My grandmother has taught me 2 or 3 herbs, I will teach you. That one help better. So they are okay like that. So come back for it. So it's very important for us to know that it's really a challenge for them. Then also the emergency units. Here, another case also happened some years back. A boy was rushed to the hospital in a clinic. But before then, this boy is very energetic. He's the one who helped the family with farming, firewood, charcoal, just for the siblings to be able to eat. He's about 16 years. And so went to the farm and was bitten by a snake that day. But he still managed to carry his firewood to the house. When he got home, the way he was reacting, like touching both legs and to the waist, even the grandmother became confused what was happening. So they were like, oh, maybe because he wasn't wearing a shirt, maybe he entered into a bush where he had some rashes. But it's not that. It was the poison that was happening. So later they gave him some first aid, thinking he'll be fine. Then they came to look for their nurse friend in quote, the interpreter. And then they were told that the nurse was on leave. They didn't say why they were looking for the nurse. Then they went back home. They didn't come with the boy. Then they went back home. They stayed for a while before coming back. That was when the boy was already going on. Finally, we lost that boy. So, assuming that one person was not even a nuclear family member, but maybe an extended family member, we would have done our best to actually save that person. Because when they got the clinic, the health workers were like, oh, our colleague is not around, that's all, what they should have helped. But you could also equally help. She shouldn't be the only person who could interpret as well. So that is also a challenge for the deaf community. So, like I said, with this presentation, it's a lived experience with me being in my brown uniform like a community nurse and being in the community for long. So maybe you might be waiting to see data that will be doing 3 years train, 4 years train. We didn't do it that way because these are innovative ideas and then we want to see how it will go. Okay. So when I got into the community and I realized that this was a challenge, I didn't wait because I remember that we were told on campus that when we come for improvise, it is common. When there's no toilet, we should use glass with that. When there are no glass, we should wear polythene on our hands. So we're doing that. So the same way, if I've also identified that there was a communication barrier and I have the skills, why do I keep it to myself? I have to also use it. Not waiting for me to be paid, but voluntarily to help. So what I do is that during the NIDs, I make sure that whilst we're focusing on using the van, we are going around. We don't need the van. We have created a WhatsApp platform for us, for those who have phones. But you know our English communication is not the same as us where we write the proper English. So it will be a broken or short form of English. Aside that one, I also work with the executives that hand in hand we communicate every day, the video call, so for education. Then on Sundays we meet where I can explain to them, that is our own meeting. So anything bothering them, anything new in the system, before maybe on that or the next week, my team begins to go into the community. Yes. Then also doing the child welfare and the home visits, the same thing. I volunteered to go because somebody might go for immunization. And there was a case like she said, I went for the first immunization for my child. And after she came home, I think the baby was running temperature. Then she called me. She said, I will not go again for the second one. She has stopped. And I said, why? She said, the baby has been crying the whole night. And so if the whole night my child is crying and I don't even understand. And when I came to the hospital, they didn't even explain to me what was going to happen to my child. And I'm already deaf. What about my child? Is it going to cause anything? So I won't take it again. So we have to just go back to that house, educate them, just take away all the fears, let them know the importance of the vaccine, and then they can continue. And that lady actually turned back and then came for all the vaccines for the child. Then also, looking at it, like I said in the first story, I wouldn't say because I went on leave or the lady went on leave in code, so there was no one to interpret. Then it means I'm being selfish. Why don't I train or help my other colleagues who also have the interest so that we can be many where they can fall on at any time for some. So we started training health workers in person, and also sometimes looking at the challenge of the no staff or inadequate staff syndrome. We have to now move online to have these sessions. Then also, this year we happened to partner with one NGO, KEPA, also known as Amaware, where we had a training for healthcare workers. This one, we dealt into every disability inclusive healthcare, so not only sign language, but everything disability, including art. And we were surprised that in that training, we realized that we are health workers, we are enlightened, but then we don't have much idea when it comes to anything disability, even the law. So if I'm not even aware about the law, then how do I even implement it? That's supposed to be a free healthcare, supposed to be without discrimination. Like the nurse once told me, please, if you come with your clients again, I'll wear gloves. And you forced me to attend to her. I wasn't comfortable at all. I'm scared my child will become one. I'm like, really? Yes. So, which means that we need that training. Okay. So we had a phase 1 and phase 2. That was in February and then in June. And we did that by mapping our sub-districts. So we looked at where we have PWDs that were dominating. So we chose APAM and we chose processes because they were the ones with the highest fee. We went there for the training. And we also have, this year we also have some celebrations. So not only this year, but usually we want to involve them. We don't want them to feel that they are being neglected because they're saying that you're taking the stigma away. So when we have health celebrations, World Joint Day, World Breastfeeding Week like we're having this week, what about the deaf community? We need to involve them as well. So we do. Then also the adolescent special health education. We have one special school in Goma, where that is the FPHC Training Center. So we do go there to have sessions with them. Then awareness creation. We don't wait for any huge program before we go into awareness. Sometimes even when we are on our normal monitoring, you meet a family and even in that same family, they don't see the need or benefit of this person who is living with a disability as their own family member. So when they are attaching that person to you, and you can imagine you're supposed to help educate this family. So right from family, they need the education, then into our own institute, the health professionals, then also the community at large. Then like I mentioned earlier about the partnership, because we can't do the work alone, so we fall on other NGOs. So we PED, it's just saying promoting equal rights for persons living with disabilities. So they focus more on women and girls. And then also KEPA Africa, that we also known as Amaware. They are anti-corruption kind of group, and so they do everything on capacity building for healthcare providers, and that's how we're able to have our training that I mentioned earlier. All right, so we want to continue with some pictures, just to, somebody will say evidence-based. These are the evidence-based of some of the pictures. So the first one is a phase 1 at Osezi, and then the second one is a phase 2 from our referral hospital, which is the St. Louis Catholic Hospital. All right, so another picture here talking about we going to the special school for the sexual and reproductive health education, because we also know that whilst we are educating adolescents that are in school, we will say normal school, different from them, because they are all vulnerable. A man or anybody can do anything at any time, so we need to educate them as well. Then the other part also is just give an evidence base of a training for healthcare providers on the sign language. Then outreach. Yes, so we went back to that same school this year, and then we were able to help educate these learners. And one of them said, Madam, so today you came here with all the doctors, because as you can see in the second picture, that is my director, Dr. Maxwell Ibuache. So, and then these are all the team from St. Luke's. And they were like, oh, then today we are happy, because all doctors coming to us, so you can see the joy on their face. And aside that one too, the workers themselves also said the same thing, that we do come around. But to bring a whole team of doctors to come to them that day was like all joy. That was in my. So we also want to look at some of the stories that we have. So we are saying that with all that we've been doing in the community in Gomua West, unlike those times where they are on their own, when their mother is coming to the clinic, then they come with them, then they go. They don't understand why they are going for ANC. They don't understand why they are going for CWC. This time, she knows that she has to go. So she is going because she knows that she can video call with me, and whatever issue is there, we will solve it. So with that assurance, she can carry her bag and is able to go to the hospital. And so we have them attending for ANC and also having a safe delivery. Then also with the family planning, yes. Those times in the community was very difficult. And not like it was that easy. Because there was a time he came to me and told me if I don't remove the jadel for her, then it means I was planning to send her to another man. And that is why I've been bringing her clothes and stuff, that kind of accusations. So I should remove the jadel for her. Meanwhile, she already have 5 children. And looking at what she was going through, and then the support coming every day, we need to rather help you so that baby will not come again. But then the family marched to my father that day that you have to remove the jadel, and how to do because they have it. But this time around, they are able to understand themselves. They said, oh, so it's fine. So I want to just have a break. So they'll have their break, and then they'll have their jadel, they'll have their infant, which is the one, they have for 3 years, and they are good to go. And they are able to have this on, focus on their apprenticeship, and we are all happy in the deaf community. Yes. Then also, when it comes to healthcare providers and then the deaf community, today, I can say that in Gomua West, everybody is happy, like seeing a deaf around and they are trying to do their best to just sign something. Not like, oh, give to a Crawford number, that statement, you don't hear it again. Now it is for all of us, the 89 Crawford, so we are all helping. And that has really improved our healthcare services for them. Then also when it comes to immunization uptake, that one too, there has been improvement. I can't remember when COVID-19 came, that my directors, I know all of us were afraid. Some of us want to take the vaccine because some people are looking up to us. But within us, we know that fear coming. Yes. So that fear was there too. They were really scared. Those who can read will go online, then they'll send me long list. They'll tell me if they take me die. I said, no, you will not die. Another one will come that if they take me pregnant, future I can't. That's how the English goes. Then I'm like, oh, no. I said, no, I've read. It was difficult. Those who in their family, like I always say, they force them. Those ones were trapped into taking it. That was also against their rights. Yes. But then those who are a bit stubborn will tell you, no, I want it, so they didn't take it. And those who were even lured in taking it by the families for the first dose, they didn't want to continue. So we have to go into the community. I through their executives as usual. We had a meeting. I explained to them, I showed my card, showed the site, and I'm fine before they were convinced. And it was a good turn up when I'll show you another picture and you'll see that they came and then we worked as a sub-district and then they came. It was a Sunday, but they came and then they took the immunization. Then also when it comes to the increase in attendance at the hospital, that one has also has improved because those times they'll be like, when I go to the hospital, nobody will understand me. So I just prefer doing my own thing. So they are waiting for their mother or their family member to just give them anything that is available as a medicine, whether it is for washing, they will drink, whether it is from the drugstore, they will take. They are hoping to be fine. That is it. But today, they know that when they are not feeling fine, they will go back to the hospital themselves. And if they have any issue, they know they will call, I will come with them, to interpret. So that is the picture I was talking about, where after going to talk to them a week before, then on a Sunday, we had 22 of them coming around for the COVID-19. Yes. Then also, that is the baby I told you about that, in my previous saying that She said she took Penta-1, and baby panic temperature, she wouldn't continue with the second, maybe has been crying the whole night. After educating her, she continued. Now baby is even a school-going child. Yes. Okay, so that is also after our training this year, June and February, for the Disability Inclusive Healthcare Initiative. So when we're done, we wanted to see how, we are going to see improvement in how our staffs also relate to our healthcare providers. So in the first picture, as we had a pregnancy school for about, I'm not sure the data, but I'll check. So when we're done, then I asked, where are my people? They said, oh, they are here. So the major figure were gone, but then among these people, we had 3 women that were having disability, 2 physical and then 1 deaf that came for the school. Then also on the other side is the man who has been sick for a very long time, has been to other clinics in other, because where our map ends, they are almost entering into Suede Road, Agona area. So they went there, but I already mentioned the facility. He's been going there, not seeing any improvement, has stopped going. He's been coughing, that you could tell that for about 6 months, and you and I will start thinking of, because we don't even wait for that 6 months. Within 2 weeks or more, you are thinking of something. Yes. When I convinced, I went for home visits, and I told him that I would come with him. When they're ready to meet me, he will come to the hospital, because now I'm also very confident that my referral point, sister is listening, I know she's listening. My referral point is now helping us so well that we have come to learn from as the 115 that we're supposed to give priority to people living with disability. So when they come, they're not supposed to join or they are not going to jump to cause confusion, but then wait for a while, then we explain to them, they will allow us to go in. And truly, our system look as it's helping us. So that is it. So I came after the webinar just to help with education, went for x-rays, and then now when we came for a review, even the PA could tell that he is really improving. Yes. Sorry, the other picture that will cover, we didn't do that. So that is a deaf mother having a child severely malnourished. So the person still goes, assuming they came for child welfare clinic, and we are able to educate them like we've been doing for other people, the 4-star diet. And so you are able to help them, oh, these are the groups, so you're supposed to eat from all of them. Assuming we're able to communicate well with the mother, who is a deaf, I don't think the child would have ended up like this. But because it didn't happen that way, we had this. But we didn't leave the child like that. We followed up on her with the help of the nurse in the community. And this picture was taken in June. Yes, so that is her now, looking very healthy. Yes. So which means that the communication actually is very important. Then also, that's another picture of during NID. So whilst we are looking for immunization, we are also fishing out for pregnant women. Yes, so I got to pick one of them that was pregnant as at then that I went for the NID. Then on the other side is a deaf woman. Like I said, now they understand. We don't force them. We are not deciding for them. You explain because they know that our interpreters will understand and they'll make their own informed choice. This is what they want, and then we give it to them. Today she's able to focus on her apprenticeship, and by December she'll be done with her apprenticeship. So what we just shared, like I said earlier, are innovatives or initiatives from Goma West District. So these are our recommendations that seeing the zeal, the joy in our colleagues that really want to learn the sign language, then it means we can scale it up so many of them could learn the language. Yes. Then also, whilst we've been here and hearing about NOP being with us, all of us accelerating universal health coverage, it means that we have model health centers. So at least if we can have one interpreter in those model health centers, then they would really help us. Yes. Then also want to strengthen the policy. Like I said, there has been amendments, but as we speak now, we don't have it. So we're still going by the old one, which I know even if they will say something out, the good ones will still be there, and the good ones are saying that when it comes to communication, when it comes to infrastructure, it should be accessible. Yes. Then we also want to allocate some budget for disability inclusive healthcare initiatives. Many times our budget or our programs, we don't have anything disability in it. Yes, so we just plan and then we are going to them. But this time around, with the guest speaker yesterday saying that those outliers that we not intentionally, but then we try to forget about them. This time around, eyes are on them to help them. And one of them is people living with disability, which means that this time around, our voices will go far where we have support for activities. Then also, we want to also enhance data collection. You see the data that I shared, and I said that it was from Social Welfare Department. They gave me 303. But because I'm a community and I work with them, with this past 14 years, I know they are more than that. Even the deaf community, because I've narrowed and I've specialized. So I have an Excel sheet. I have 96 assets. We are in August. So last Saturday that I went to the community, I have 96. But they are giving me 85. So even with this in mind, it means that there are still more people for us to look for. So if there's a way that we could actually have our own way of capturing our data, that will help. Because when Keba Africa came, they have made the effort they have good initiatives to actually support us. I don't have data. When they went to where they're supposed to get it from, they were not providing. That one, I can't say much here, but then they were not willing to release the data. And what they have are what they are giving me to work with. But because I am in the community with the people, I try to look for them myself. Then also, with this, we are saying that we want to leave it as a baseline. And so I say it's an honor to be here to present on these initiatives. So we want to leave it as a baseline where the region can look at it and we'll have future plans that will help the region and also all other districts to benefit, and then even national. That will be very good. So whilst we are going home from this discussion or this small short presentation, we are saying that when we are attending to any person living with disability, we are not doing a charity work for them. Sometimes we think that we are helping. No, they have the right to it. So it is justice, it's not charity, it is justice. And also we are saying that whilst we are doing our best, trying to contribute our quota so that we'll be able to accelerate universal health coverage, we are saying that we need to ensure that we don't leave anybody behind, especially when it comes to communication. It shouldn't be a barrier. Right. Okay. So we are saying that when we are able to put all this together, we have a dream. So sometimes you have your own dream, and that is what motivates you in your room before you come out in the morning. That we want to see Goma West, and also want to see all other districts, see Central Region and Ghana to become disability friendly someday. Thank you.
I don't know how many districts have disability-friendly initiatives in healthcare. And you said you've done this for 14 years?
Yes, sir.
Maybe we should clap for that. Do you have any questions or comments on this presentation? Please, can you take the mic around? Please go on.
Good afternoon, Director. Good afternoon. I would compliment you. You have done so well done. And seriously, you have done a lot. Thank you. I work with St. John Abolanzana. I'm the regional director. And I have learned sign language. And I know how to to get to the heart of these people. Sometimes you feel that they don't understand us, but it is a whole culture on its own. To get to the heart of the person, you have to know the language behind and what she's doing. And I can say that from your perception, and look at the good stories you've given us, you've done very, very well. And St. John Ambulance is also doing a good work. This year, we are also going to the school for the deaf. We train people on first aid. So my focus was to go to them and also teach them first aid skills. Especially we see accidents that goes on in schools and how we also handle it. I saw it as a project, and that they also need the help. You know, when they learn from infancy how to handle medical emergencies themselves, when they grow up, it comes to them. So I would say that we want to support Ghana Health Service in everything that you do. Please call me. I'll be ready.
Yes, okay, so this one is my policy contribution. She mentioned data use. Now, with policy, we do the two things. Some of the policies are for equity. Equity means that it shouldn't be the majority before we fund it. So when you are seeing data here, you are not going to say, let's say 900 overpopulation. Let's say it's 1%. We don't use that in policy advocacy. You use the numbers that we have 900 disability people in the region. When you write it that way and you speak from that perspective, then your advocacy can generate resources. But I noticed that sometimes some of our directors, some of these equity indicators, they use percentage. And then when you use the 0 point something. So that's what I'll tell you. So that for some of you who are going to budget for this, the logic, when an auditor comes, the logic is not the percentage OPD, the percentage is, it can be one out of all the OPD, but it needs to be budgeted for. And I'm using another example. When you take the policy for free primary health care, they are using population-based. Population-based is, we call it efficiency policy. It's population-based. Go to the north. You can have some 6 people who live in a particular community, and they have to build a clinic for them. It's just 6. They cannot run the overheads of the facility and things, but they have to budget and do that. So this one is an equity argument policy. So all of you who are going to budget for it should use equity and not efficiency to go and argue in it. Thank you.
Thank you very much. Any other question or comments for Akosia? Okay, Akosia, you've done this for 40 years. Have you published any paper on this?
Okay, thank you for...
Because you must have some rich data somewhere.
Okay, so I partnered with, so I'm a co-author to so far 3 papers that have been published.
As a business club for her. It needs a lot of motivation because I'm falling in love with this area, and so please let's partner to see if we can do more research in this area, because I believe that there is a lot going on in those communities, and therefore, and I also can predict that there are very poor health outcomes among those. They are being left behind. I think we need to do sort of draw some policy in that area to influence those living with disabilities. Thank you very much. So let's talk after this.
Thank you very much. Thank you very much, Dr. And I am very glad all of you are clapping for Akosia. I met her by accident at a nurses forum, and I am sure most of you, especially my SMC, will get me out about disability. It's always in our agenda. And when I opened the floor for questions, I said the nurses should vent. So there was a long queue and I didn't stop them. And as soon as she started talking, I quickly wrote her district name and I plugged her out like that.
I just thought that instead of me to come and tell SMC that I found a gem, I should give her the stage to share what she has done before I appoint her as focal person for disability for the region. Her leadership and support her. And without saying anything to anyone, you see academia has reached out, ambulance has reached out. I am sure a lot of you have reached out in your hearts, it's just that you are not holding the microphone. So after this, as I said in the morning, we'll share the Google Forms with you. We've worked on it with her already. We'll share it. Just answer as you know how it is. We don't need to lie about anything. If it's there, if it's not there, it's not there. And then we'll see the gaps that we have in our system. And together we are going to work to address these things. As she was presenting, you were also thinking about different things you can do in your facility or in your region. So when we start discussions, remember that so whatever approach we use in the future may be different from AE, but in the end, it will get all of us there. So, Gifty, thank you very much, and we are very grateful that you did.
Thank you very much, Director. So, we will push the agenda. So, the next presentation is by Dr. All right, so let's build this consensus. I hear lunch is ready. So can we take the mental health updates now, go for lunch and come? Or you want us to finish? You want to go and eat and come, right? Okay, but let's do the mental health. Let's call Dr. Julius to do that. I'm sure that will also be an exciting one. Let's clap for him as he does. Now the energy is going down. I can feel the energy. It's going down. Okay.
Kingdom Fire. Kingdom Fire.
Evening. Good afternoon. I'm presenting on behalf of Ankafo Psychiatric Hospital, representing my hospital director, Dr. Julius Hatchet. Dr. Julius Hatchet. I'm Solomon Yaboa, public health officer for the hospital. Our presentation basically will focus on the strong collaboration between your hospital and then the regional health directorate. And apparently our director has been very instrumental in every activity that took place for the first half of the year. Because we know most of the activities is done at the CHPS zones, the district levels, the polyclinics, as well as the hospitals. Now, this will be an executive summary, a brief overview of Ankafo Psychiatric Hospital development activity that was carried out recently, and then the collaboration, as I mentioned earlier, with the Ghana Health Service and then other health agencies. So just a brief overview. The hospital established in 1965 basically runs a capacity in the region and then provides services to all category of persons in the region and then beyond. These are the services that is being rendered. We carry out the psychiatric OPD and then admissions, the general medical and detention, the RCH, lab, pharmacy, drug and alcoholic rehabilitation, epilepsies, HPTs, and then the diabetic clinics. We also carry out occupational therapy, the community psychiatry,
the psychiatric social welfare, the child and adolescent mental health. We also have the counseling and then the clinical training for all caliber of professionals. And then we also conduct outreach clinics. So our services goes beyond. Now, geographically, our clients are mostly distributed across the country. Since we are in the center of the region, the country, which is central region, most of our clients fall within that very jurisdiction, that is central, and then followed by western, Ashanti, western north, Greater Accra, eastern, Ahafo, Bono East, Volta, Upper East, Upper West, Savannah, Côte d'Ivoire, and then the Oti regions. So basically we have clients coming from all these jurisdictions to access the service in our facility. For this half year, the hospital, with this strong collaboration with the Regional Health Directorate, we undertook a purple month activity. The activity was geared towards mental well-being for all. That is turning awareness into action, where we focused on moving beyond awareness by rather encouraging practical steps that support mental health and overall well-being. Now, as part of that was being carried out, as part of the activities that was carried out, we conducted free specialist outreach clinics. We also engage in general medical consultations, psychiatric assessment, health educations, visits, we did radio health discussions, school health programs, faith-based engagement, community members, and then we also engage in referrals for specialist care. So these were some of the activities that was being carried out, free specialist outreach clinics. So as you can see, we visited the Aguna Municipal Hospital. We also visited the Asim Fosu Polyclinic, and then the Chopopraso Polyclinic. As you can see, here screening was effectively conducted on maternal and child health, where using our IKL tool, we screen for postpartum and then perinatal depression for our pregnant women and those that have delivered. And as you can see, my director in there, and this was consultation sessions by our specialist, the hospital director, and a psychiatric specialist. And then we also provided, that is free medication for all as well. And then we visited the faith-based and herbal centers. As you can see, we visited the Mempasem Nyamibeye Kesi Herbal Clinic, where they produce their own concoction to believe, to care for the mentally challenged individuals. And then we also visited a prayer camp as well. And then school health and radio engagement. So we engage the schools to take them through. They need to be aware of their mental health. And then radio engagement. And then other training sessions. We also collaborated with St. John's Ambulance. In fact, they've been very instrumental to the hospital, as far as the regional director of health services is concerned. And they provided an effective training for the facility. And as you can see, a huge number of staff partook in the exercise, and it was very instrumental. It's still carried out. Still you can see. And this was a multi-sectorial stakeholders, where we had the chiefs and other dignitaries. Training sessions. The engagement also provided 2 online training sessions with an average participation of 120 CPNs, that's the community psychiatric nurses, in the region, and it was focused on the maternal mental health. Currently, we have the maternal mental health policy. So they were trained on the policy and how practical it will be in the various the district as well as the facilities. Now, this is what we are looking out for. To still continue the online training session throughout the year. To sort for sponsorship with support from the Ghana Health Service, with the support of the Regional Director of Health Service, and then other stakeholders. To also conduct 4 more specialist outreach and therefore appeal to the medical superintendents and directors from the various districts, hospitals, polyclinics, to support these initiatives before the end of this year, and then to further provide supportive supervision to all our various districts, hospitals, polyclinics, others throughout the use of tele-psychiatry. Very grateful. Thank you.
Thank you very much. Any comments or questions for you?
Thank you, and thank you for the great work you're doing to support mental health in the district. My name is Dr. Paul. Maybe people are not seeing me because I'm aged. My question is about sustaining the impact of what you're doing at the various levels. Beyond the specialist outreaches, what is the plan to build capacity to continue what you're doing? Like how you saw the maternal cases, apply the screening tools. How can we sustain that? Have you thought about that? What are your plans? So that we can also know how we come in there. Thank you.
Thank you. Any other comments? Let's take about 2 more.
Okay, thank you very much. I want to find out what we're doing for staffs, because we may not even know we have mental health issues. So if you are doing specialist outreaches, can you also have maybe zona or that's into this form? Okay, and then we are coming for specialist outreach. So any staff that think needs to see a specialist can also have that opportunity. I think it will also help us, because there are a lot of people, I may be one I never know until I see a specialist. Thank you.
All right, thank you. The last one.
Thank you. Mine may be a bit different from what he's presenting on. In Cape Coast, whenever we have a meeting, the Honorable MC talks about the vagrancy within the metropolis. And sometimes they want us, we at the health directory, to give a solution to the issue. And it becomes difficult because it involves policies, it involves social welfare. So maybe we meeting and thinking of how we can take care of the vulnerable within primary health care. Can we think of that issue of vagrancy within the streets, within the Cape Coast and other places that have those issues?
Right, thank you.
Okay. Please, Prof. Please, can I answer some of the questions? Please, yes, that's Dr. Julius Hache. Forgive me for how broken my voice sounds. I have a very terrible cold. That's why I had to let someone else do the presentation. But I still have to speak anyway. Yeah. So, by way of sustainability of some of these specialist outreaches, as my public health officer mentioned, we have actually started building the capacity of those who are at the forefront of rendering primary mental health care to our brothers and sisters within the communities. We started last year with a series of online training sessions and we continued this year, preceding the launch of the maternal mental health policy for Ghana. That happened, was it in March? The plan is to continue those sessions, build the capacity, empower them as much as possible to be able to at least do the basic minimum in terms of triaging cases, knowing which cases should be managed at their levels, which cases that need to be referred, and even sometimes to be able to provide some form of supportive supervision to them at the level of the community. We want to go ahead to utilize telepsychiatry services, as have been mentioned, to see some of the cases, possibly go through the entire motion with them. By so doing, they will learn and be able to do. Because the truth of the matter is that it will be very difficult, or it's not. We are not going to be able to get psychiatrists and psychologists or psychiatric social welfare, social workers to every CHPS compound anytime soon. And so we need to be able to bridge the gap of distance anytime soon with the use of things like technology and so on and so forth. So that is why we are buying into the whole idea of using telemedicine approaches or technology approaches to solve some of these problems. The second question that has to do with staff and taking care of the mental well-being of staff, it's a collective effort. But at our end, what we are currently doing is that we have dedicated Wednesdays from 10 a.m. to 12 p.m. to staff. So staff not just from Ankafo Psychiatric Hospital. Once you are a health worker coming from any part of the central region or even any part of Ghana for that matter, and you come within that period, we give priority to staff. We have a special doctor, a special psychiatrist that is dedicated to that particular clinic, and you will be seen and attended to at no cost at all. I think the next step for that could be we being invited by the medical superintendents and then the district health directors for special outreaches targeting just the health workforce for that matter. I think most of these outreaches we've done, like was rightly mentioned, was targeted at members of the communities, sometimes excluding the health workforce for that matter. And so that is why we are pleading with the medical superintendents and the district directors of health service that these outreaches can be very expensive, but we are able to reduce how costly they are as much as possible when we form good and working alliances. We collaborate effectively, and on that grounds, I want to applaud the regional health director so much for her key role that she played in the ones that we are able to execute already. I think in all the places that we got tremendous support from on the ground, which was facilitated by herself. So we want to, before the year comes to an end, we are hoping to have at least 4 more of those. And then, God willing, we will add the staff to it.
Thank you very much.
I think the issue
of
the
staff coughing.
The issue of the migrancy is another challenge that is confronting us here in Central Region. I think the numbers are more massive than anywhere in Ghana that I have seen so far. But like has been rightly said, it's not one person's job. At Ankafo Psychiatric Hospital, we may have the infrastructure, but it is not even in the right shape to house all these people. But when you pick them, they will need medications. They will need to be fed. Yes. At a certain point in time, we need have a plan for social reintegration. And that part, social welfare, local governments and things have to come in. How do we empower them with the necessary skills to be able to go back and become productive? Because, mind you, mental health care has moved from the stage of institutionalization to community-centered management. And so, if we manage them, if we're able to manage them in the hospital, settle them, and get them repatriated, what are they going to do to keep or sustain the healing that they have received at the end of the day? And so I think this requires a bigger stakeholder forum for us to discuss this comprehensively and then be able to execute it successfully. Thank you very much.
Thank you. All right, so we'll let Director say a few words.
Thank you very much, Bob Chair. Thank you, Dr. Hachi and Public Health Officer Yeboah. Great. So thank you very much, and I also thank the audience for engaging mental health. Indeed, there's a lot that we can put together for ourselves and also for others. The only comment I want to make, in addition to what Dr. Hachi has said, is the fact that the issue of the vacancy is alarming. It's, I think, the first thing that you notice when you come into the region or you come into Central Region. And Regional Health Management Team and Regional Health Committee have been discussing this. So we even thought that the Yesupom Center, which is in Elmina, I'm not sure if all of you know about it, but there's a rehabilitation center for mental health, people who need rehabilitation. We thought that we could use that facility for what we call housing first. Housing first means that these people that we see on the streets, they are not living anywhere per se. So with the support of the security agencies and social welfare, we could take them or pluck them off the streets. But if we take them, we cannot take them straight to Anchor. We need to put them somewhere, clean them up, give them food before we call Dr. Hachi and his team to come and give them the medical attention that they require. So that is where the housing first approach comes in. So we're looking for a place where we can say, okay, we have a building here, we can use it for housing first, whether it can house 10, 20, whatever. And that is why we started making the inquiries. So I told the Municipal Director for Elmina to follow up, and he also teamed up with Dr. Hachi, and they went to see the NCE. I have a full report on this. They went with all the stakeholders who are supposed to be there. They examined the facility. It is there, but it is only wobbling on its feet because it does not have the resources to make it vibrant. So it is for occupational training, therapy, rehabilitation for people who are recovering from mental ill health. But it is actually not a place we can use it as housing first. It's got its purpose, and we need that. So if we have any funds, we have to make sure that it is working as it was supposed to, which means that we still need to get a place for the housing first approach. If we don't get a place, then the people continue to be on the streets, and sometimes they are menace and a danger to us. So this is also saying that it is one of the things that we need to discuss. It is in our list of things to discuss when the regional minister and the local government people meet us. Because if we want 2 chips to be built per year, we can also agree that yes, 2 chips per year in these districts, but in district A, B, C, instead of 2 chips per year, we want to use that money for the housing first approach, so that we can have some designated places within the region where we can send some of the people roaming our streets to rehabilitation and then for treatment. So thank you very much. All your comments are welcome. At least not at this time, but you know how to reach us. Thank you.
Thank you, Director. So let's start for ourselves. We've done so well. Therefore, you have ended your lunch. How many minutes for lunch? 30 minutes. So you have to eat like you are at military training. 30 minutes exactly. be. Thank you very much.
So please 1 minute. So when you go down there, please settle on your seat. You have